In last session lecture, we touched upon the fundamentals of global health diplomacy, which was fruitfully delivered by our colleagues from International Health Policy and Practice, Dr. Walai Porn, Dr. Viraj, and Dr. Piraya. Yeah, we touch concepts and definitions, actors, multiple collaboration settings, the why and the how, and some expected competencies that we need to work on together. Yeah, to prepare us better to become a global health diplomats. And from the perspective of Indonesia as well, we see that in our effort, in our country's effort, diplomacy is actually a catalyst for development. And there were some notable achievements and success stories. And this is actually what we are going to exercise more, both in our synchronous and asynchronous sessions. That there are challenges and opportunities, and we are actually the agents that are that are being prepared, yeah, to be ready to take upon the role in Indonesia health diplomacy floors. And what we exercised in last session is basically seeing a comparative, seeing it in comparative lens in Indonesia's effort and Thailand's effort in actually advancing global health diplomacy. And some of the areas that we discussed and actually became our case studies at the end of the session is that what is global health diplomacy from your view and how is it important? I think from a case study, and we will touch this later on in our afternoon session. Some All of us have now possessed an understanding of what the definition of global health diplomacy and how is it important, and and more importantly, there is room for improvement in each system. What went different, what went successful, and then what can we learn and what can we not learn, and what can we learn and yeah, in Thailand's effort compared to our own. What are the actors in health diplomatic realm? We saw that from the last presentation that there are bilateral organization, multilateral organizations that were formed in conjoining efforts in global health diplomacy, which we will actually talk more in some of the topics for today, especially in negotiations and other observations. I think we have a very rich cases of how global health diplomacy can be our platform to move our cause forward. So basically, health and diplomacy, and this is really putting it in context. The discussions that we had is on whether it is actually a foreign policy in health, or health and foreign policy, or is it both? And please observe the readings that are given in Sakai and some materials to really touch down upon the concept and the intersects between these two theorem. We have obviously there are so many things that we can touch upon in answering these questions, but this is more a conceptual, more in conceptual manner. And in global health diplomacy itself, is it categorized as soft power or hard power really? For when we see at the image, actually, global health diplomacy can be categorized as more of a soft power. And when we see that, but that doesn't mean that we can exclude politics from health, from global health, because the we have instruments actually that, and this is politically connected, um, between diplomacy and global health. We talked about some of the instruments, and we will talk more about it in our next courses, and how we can prepare for instruments in global health diplomacy so that we can actually take part better in this area: negotiations, resolutions, international agreements and conventions, regulations, what is binding and non-binding agreements. Those are things that we were going to cover the next. But before we move on to that, we want to make sure that we know the concepts behind it, and how do we generate that concept into more applicative settings. And this is just to highlight that politics, diplomacy, and public health, historically and both globally and Indonesian specific, is really interconnected. When we see in 1960s, for example, in the US, there's a HIV/AIDS epidemic. There was, and back then, this epidemic started really was kind of similar with what we experience with COVID now. People didn't know what HIV/AIDS were, and because it took so many, it took a heavy tolls. Um, some areas began their initiatives, and what we see right now, as for example, like community owned treatment program in AIDS, this collaborative, or what we call San Francisco model, is actually was part of the local diplomacy and advocacy that were later on recognized by US, and then that actually pioneered some of the global health response and AIDS as we see today. Um, uh, Moving on from San Francisco model, US recognized Ryan White Care Act, which marks the political commitment for HIV/AIDS prevention, and now we see that it serves as a way forward for some of the organizations that we know today, PEPFAR, for example, and then OGHD, Office of Global Health Diplomacy in U.S. Department of State. I recommend, if you have time, to watch How to Survive a Plague. That is a documentary actually on how HIV, which started as a local initiative, now became a global coordinated response. And that is the global health diplomacy was a huge part on that. And in Indonesia itself, our effort in achieving UHC, it cannot be separated from politics and diplomacy. Actually, when in 2001, when we have idea for social security reform, which was enacted in 2004, in the same year, in 2001, the decentralization occurs. Many local initiatives were undertaken because at a similar time, the social safety net for health was also stopped. And by 2005, UHC, as direct elections for local leaders also were introduced, UHC becomes an electoral asset. People advocate for UHC in a more micro scale, local scale. We have Jamkesda in many regions, and this has become a powerful political reasoning at the time. And by 2011, BPJS, or Social Security Agency for Health, BPJSK, mandating law was formed, which came into being in 2014. Even though there is a leg process, advocacy and diplomacy took part in that, in which civil society organizations came to help enforcing action for BPJS law. And that is what we know today as JKN. The process itself cannot be separated from politics and diplomacy in advancing public health cause. So where does it leave us? On diplomatic front, efforts for coordinated action are actually imperative in negotiating frameworks, for example, and consolidating agreements. And it is a task for us, the global health diplomats, to ensure that policy coherence among diplomatic and public health forums are ensured, and to effectively use soft power exercise and tools. We have values, we have tools and norms, negotiations, agreements, and how to orchestrate that in a really coordinated way is it's our job for now and probably years to come. I just snapped this from U.S. Foreign Service. They have 13 basic qualifications on becoming a foreign diplomat. So those are 13, but later on from these sessions now on, we will touch upon some of the in depth of some of the tools, important tools for diplomacy in global health. May I remind you again on Pak Firoj's point on global health competencies? We acknowledging national and global issues, the priorities in regional and global, knowing what platforms are there. They are going to facilitate these discussions, which are the stakeholders, and last but not least, and ultimately, technical knowledge and skill that we need for better coordinate our global health diplomatic response. So that leaves us on what we will learn and exercise today. We will touch upon the concepts and maybe have a panel discussion. Please ask questions in the to the speakers, because we have a very experienced and fruitful speakers, and I hope that we can have a much more fruitful discussion in our smaller group on leadership and negotiation. So I just want to start today by this quote by Rudolf Virchow. Was a long time ago. Medicine is a social intersection, and politics is public health in the most profound sense. And from that, from that idea, is why global health diplomacy is something that we need to be discussed. I think that's it from me. Um, Let us move into this second session. Thank you.
Sure, Dr. Yan, thank you very much. Maybe you want to have a question and answer session, or maybe a sharing session from the participant or the facilitator before we start the second session in 9:30, Dr. Yan.
Yeah, sure. If we have time, then please have the floor. If you have questions and then maybe some reflections, we will have that later on in the afternoon session. But please, if you do, Pak Pak Himawan, of course, I will share this presentation. So in each morning, we will have reflection session, really just to make connections between the last session that we have and then the session that we're going to have today. I think we can definitely give the floor to give the link to the presentations of today later on at the end of the session. Is there anyone that wants to share maybe the reflection from what we have in the first session Saturday, and then the I wouldn't say controversial, the asynchronous sessions that we have. We've seen the case study one that and case study two, and we're gonna have more in-depth discussions on that. We've seen the position paper. It's all fruitful, and really what we want is that while there's a concepts that we give, actually we can learn also together on how actually we can practice on hand on these tools. If you have questions and want to share, please do.
Uh, Arian, Pak Andrew, may I ask a questions?
Yeah, Pak Ferdi.
Yeah. At the case study one, I see that we make a difference. What is the difference between Indonesia and Thailand in terms of global health diplomacy? So I believe that participants see from the presentation of Dr. Firoz, actually, there are many similarities among us with Thailand. Yeah, we are involved with, in cooperation with Thailand in ASEAN. Yeah, we involved in Forum FPGH, Forum Policy of Global Health, and of course in WHO. Yeah, so I think when the question, what is the difference, is quite difficult actually to analyze. What is the difference? So what I see is the Thailand maybe advanced in the issue of universal health coverage. So Thailand is also prompting or make a universal health coverage in all issue, all negotiation he take, because universal health coverage is very broad area. We can there will be 6 health system inside, yeah, including medicines, uh, funding, health workers, something like that. There's so many issues that related that we can learn from Thailand actually, how to increase, how to make it advance. The universal health coverage implemented in Indonesia. And then Thailand also, I remember that would like to make a collaboration if Indonesia would like to propose the resolution about the mental health. Maybe Pak Rabudi is still remember about that. If it's still possible, us to make something as a co-sponsor of a mental health issue in the resolution of WHO, because now mental health is very big issue for the health workers, for the people who they are afraid go to the facility of health because of COVID-19. There's maybe some implementing the technical issue that could be raised, so the participant from the technical unit related can thinking what kind of cooperation then that we can develop with Thailand, yeah, because I think we have a close collaboration in many areas with Thailand, but as long as I know, like we don't have any MOU yet, bilateral MOU yet with Thailand. Maybe this could be is a initial step to make what is the benefit to make a collaboration, bilateral collaboration with Thailand. I think that's what I can add. Maybe you can explore more about the what kind of collaboration we can make with Thailand. Thank you.
Yeah, Pak Ferdi. But before I begin, Pak Rahbudi, do you want to share what is your thought on the global health, global mental health collaboration? Because I believe, and I believe that we have shared the paper, the call of paper that were shared by Dr. Firaj. If not, we will share it later on as soon as possible. But what is your thought on building the collaborations on that? Do you see if there is any room for collaboration actually between Indonesia and Thailand in that issue, specific technical area?
Thank you. It's about the mental health issue that we have been building the collaboration between Indonesia and Thailand. Uh, Facilitating with the Asian country, we built the mutual cooperation in mental health, especially in PMI. PMI is a migration worker. So before we depart from Indonesia and after we receive the return of mitigation worker, we together with the foreign affair work together in assessment of the mental health status. So some of the case after the worker return back to Indonesia, they suffering some of the mental health problem. So we work together in countries that we send the migrant worker to have like a resilience. It's about how they can coping of like like we say, it's about the distress or something different that they receive at the workplace. So we work together with the foreign ministry to early detection of a mental health problem in the country that they work abroad. I think this is temporary that we can send something. We work together with WHO as well, that we have a mental health atlas That's about the secondly, we have uh, mental health hubs, yeah, digital hubs, as a collaboration globally that we can share the data and the mapping of mental health problem. So we can cooperate together that we can anticipate the rising number of the case of the mental health. Thank you.
Good points, Pak Rahbudi. And I do encourage us to talk more after this to Pak Firoj actually, because I believe Pak Firoj can connect us to the right person which can initiate this collaboration better. You mentioned about there are some potential ideas and historical progress made by Indonesia and Thailand, and let us move with that for better collaborations among two countries. As mentioned, bilateral coordination, bilateral cooperations like this are actually a start of something good. Andrew, shall we move on to the discussion, or shall we now move to Dr. Pem Namgyal's session? Please advise.
We can continue, Dr. Yan. Thank you very much. Sure. Then thank you very much for the warm reflective session from Dr. Yan and also from the facilitators and participants' perspective. Please allow me to once again welcome our respective speaker, the first one, Dr. Pem Namgyal, as the Director and Program Management of the World Health Organizations for Southeast Asia region, and the second one, Mr. Ambassador Sunu Mahadi Sumarmo, MA. We are definitely thankful to have you within this virtual workshop. Before we start the next session, please let me give one golden poem from Indonesia. Berakit-rakit ke hulu, berenang-renang ke tepian. Bersakit-sakit terlebih dahulu, bersenang-senang kemudian. Although you need to spend your weekends to sit within this virtual workshop, but trust me, you will get something important yet insightful which may create a better version of yourself soon or later in the future. Like a rough diamond, the more polished the diamond, the more beautiful it will be. For the second session, we will have two lectures about leadership and negotiations in global health, which will be led by our respective moderator for the workshop, Mr. Ferdinand S. Tarigan, SKM, MKM, from the Multilateral Health Corporations for International Corporations, Ministry of Health. A brief summary about him. Pak Ferdi is graduated for his bachelor degree of public health from the North Sumatra University and continue his study as the Magister Administrations and Health Policy from the Universitas Indonesia. He also has several experiences, which but not limited to being the Assistant Deputy Director and Deputy Director for the Multilateral Health Corporations Bureau for International Corporations Ministry of Health. Without further ado, Pak Ferdi, the floor is yours.
Thank you, Andrew. Thank you for your warm welcome. Good morning, everyone. Nice to meet you again virtually at the Saturday 2 of these synchronizations. I hope you can hear my voice clear, yeah? And I hope you keep your spirit up and have a strong motivation to follow all these sessions, although today is already weekend. I will be your moderator from 9 to 12, so bear with me. During that time, we have two speakers that already mentioned by our MC. So thank you, Dr. Pam. I see you already in, yeah? So I would like to introduce Dr. Pam. Dr. Pam, WHO CRO India, from Director Program Management, yeah? Dr. Pam obtained his medical degree from the All India Institute of Medical Science, New Delhi, and his MPH from Johns Hopkins in the US. After 15 years of illustrious career in the royal government of Bhutan, Dr. Namgyal left to join WHO in the Department of Immunizations, Vaccines, and Biological as medical officers for new vaccine in WHO headquarters Geneva in January 2001. In that position, he was responsible for the rollout of new vaccine in the Gavi eligible country of the world. He then moved to the WHO Southeast Asia Regional Office in 2003 to continue to work in the areas of immunizations and new vaccine. However, in 2009, he was asked to return to WHO headquarters to work in the Department of Initiative for Vaccine Research on 3 neglected vaccine preventable disease, namely cholera, dengue, and typhoid. In 2013, he decided to return to WHO Southeast Regional Office in Delhi to continue to work in immunizations. In early 2014, the newly elected regional director, Dr. Poonam Kethapal Singh, appointed him as the new executive officer to the regional director. He was then selected as the director, Department of Family Health and Life Course in 2017, and in December 2018, he was appointed as Director Program Management and continues in his position. Before I give the floor to Dr. Pam, I would like to remind all the participants, you may put your questions at the chat box. You may put your question at the chat box while the presentation going on, or request to deliver your questions directly to the speakers by typing your request in the chat box. Now, I would like to give the floor to Dr. Pam. Dr. Pam, the floor is yours.
Good morning, everybody. I would like to thank Professor Adik and team for giving me this opportunity to speak today on this important issue of global health leadership. I would like to add, in addition to all that was said by Andrew, I would like to add that it is a pleasure to see Professor Adik again. I had the pleasure of working with her in CRO in the early 2000s. So it's a pleasure to see her still very active and taking strong leadership in this area. So I was asked to speak a little bit on global health leadership, and it is my pleasure to make a brief presentation. I hope to speak about 20 minutes or so, and then have more time for discussion. So can I have the next slide? Okay, so I was asked to talk on the topic of global health leadership. And I was trying to look around to see what do we mean by global health leadership. I have to say that although there are many courses on global health leadership, I could not actually come to any specific definition of what do we mean by global leadership, global health leadership. So I thought, simply put, global health leadership is the collective, strong, dynamic, and resilient leadership in health at the global level. Such a leadership is essential in today's world to shape and drive global health governance, which actually is the main component of what we're talking when we say, when we are discussing global health leadership. Global health governance, which WHO defines as the application of rules, both legally binding and those known as customary or referred to as customary, relating to the global management of health issues. Next, please. So when we're talking about what do we mean by rules? So the reference to rules in global health include those internationally binding provisions relating to public health. And currently there are two important ones. And one is the Framework Convention for Tobacco Control, FCTC as it is known, which is legally binding. And then of course the international health regulations. Then the customary or those that are voluntary accepted provisions are those that come out of various governing body meetings, such as the World Health Assembly, and at the regional level, such as the regional committee, and then specific global mechanisms that come up with specific guidelines and conventions and frameworks. An example being, for example, the classification of diseases, GMP, WHO code for international recruitment of health personnel, etc. Next, please. So one may ask, why is global health leadership important, and why it is important now than ever? I would say that all of us are struggling today with the global pandemic due to COVID. And I think this pandemic demonstrates beyond any doubt the importance of the global community working together to deal with this. And to do that, we need to have leadership at the global level. So as you know, as of today, the virus have infected more than 32 million people, and we are getting closer to a million death very soon. We are short by, I think, something like about uh, uh, 12,000 or so to make it 1 million. But more important, and then the morbidity and mortality from the COVID is the socio-economic impact that it is having the world over. And I think I need not elaborate on what is happening all over the world as a consequence of this pandemic. Therefore, an agile, dynamic, and fit for purpose global health governance is critical to meet such challenges. Next, please. So let me talk a little bit about the evolution of global health governance, or why we now refer to as global health governance. In the earliest times, when public health became a discipline, or public health was considered as a discipline, the focus was primarily on national health issues. But as trade and travel became more common, then it crossed boundaries and became international health issues. But today, it is far more than that. Due to globalization, liberalization in so many aspects, privatization, and very powerful private players, the importance of health and environment, trade and travel, all are inseparably intertwined. And therefore, the need to engage all stakeholders became critical, and to lead the health paradigm shift, or I would say has led to a paradigm shift in the last decade, from health being not just international, but truly global. And therefore, the governance of it has to be also global. And that is how the whole concept of global health governance, or the importance of global health governance, has emerged. So how is this global health governance shaped or formulated? Next slide, please. As you know, WHO was established in 1948 as the special technical agency to take the lead in all matters related to health. And WHO's mission is to ensure the attainment of by all people the highest possible level of health, and health defined as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Next, please. So the governance of WHO, or the way WHO is governed, is, as you know, WHO being a member state organization, it has got three levels of governing bodies. First is the World Health Assembly, which is the apex organization, or the governing body, where all 194 members meet every year in May. This year, unfortunately, due to pandemic, we could not meet physically in Geneva, but we had a virtual meeting. So the assembly takes place every year in May, where 194 member state representatives and participants from all sectors, all stakeholders, come together to discuss and agree on important initiatives on global health in that. In order to support the assembly's work, we have the executive board, which has got 34 members selected on a 3-year basis amongst the member states. And the executive board meets for a longer duration in January. And the executive board prepares basically the groundwork, the resolutions, and the key issues to be discussed at the assembly in May. And then there is a shorter executive board meeting following the assembly, primarily focused on administrative follow-up emanating from the assembly. Now, in order to support these global level initiative, as you know, WHO is a decentralized organization with 6 regional offices where the regional directors are elected by member states. And therefore, at the regional level, the governance body is the regional committee, which then, of course, deliberates and comes up with resolutions related to the governance of global health at the regional level. Next, please. Next, please. I think I have covered this. Is just giving you a little more detail. Yeah. Next, please. Yeah. Yeah. Next, please. Yeah. So, why is WHO important, or what are the comparative advantages of WHO in this, or as the technical lead? So WHO is the leading generator of reliable information, data, and guidelines, the normative functions of WHO. WHO is also considered as the trusted, neutral provider of support, advice, and expertise to assist countries, because we are a member state organization, and WHO is seen as independent and not accountable to any one specific entity as such, but serve the interest and purpose of the member state. WHO's main mission being, of course, health. WHO is focused on protecting from risks to health. And one of the main advantage of WHO, since we are a member state organization and we have WHO country office presence in over 150 countries, and at the global level, WHO's convening power is unparalleled, and WHO can bring together not only member states, but all interested parties, experts, and anyone that is relevant to come together to discuss and to advise WHO on what should be done for global public health. However, as you all know, in recent years, particularly after the 2014 Ebola outbreak, WHO has been under a lot of criticism, and member states since then have been demanding that WHO needs to become an organization fit for purpose. And currently, there are several streams of the reforms undergoing within the organization. Next, please. More importantly, I want to say that today, there are many big players in global health other than WHO. While WHO is the mandated technical specialized agency for it, in recent years, there has been, sorry, yeah, can you keep that? In recent years, there has been a plethora of foundations, organizations, entities, groups that have come up that are playing very important roles in driving global health agenda. Just to mention a few, as you know, the Gavi Alliance, which was established in 2000, primarily to work in the area of immunization and vaccines, now has become a very important international NGO. Likewise, led by the United States of government, the Global Fund was established to combat TB, malaria, and HIV. And these agencies pump billions of dollars now into countries to deal with these organizations. And likewise, now there are private entities, foundations such as Bill and Melinda Gates, with a lot of money and playing very instrumental and significant role in driving public health issues. So the point I want to make is that global health governance have gone beyond just WHO, and now involves a very large number of very important and I would say deep-pocketed players that drive the global agenda. Next, please. So there is the whole concept or the uh, uh, vision behind the drive towards global government is that there is an agreement that the vision of global health government reflects a shift of perspective in terms of health as a global public health good with inherent principles of accessibility, affordability, and equity. That it is structured on the premise that national governments alone cannot address the complexity of factors which directly or indirectly impact on health and vice versa. And therefore, to achieve the above mission and the mission, global health diplomacy takes center stage. Next, please. Sorry, can you go back one? Yes, thank you. So, um, realizing this, the global health diplomacy, the term global health diplomacy, and I think the area, the work in this has become important because um, discussions of health is no more only within the boundaries of health people. I know many of you have been to either EB or both World Health Assembly, and definitely many of you have been to our regional office, regional committee meeting. In the early 90s, I have attended regional committee meeting in Delhi, where you have two or three participants from the member states, from our 11 member states. And then a few others. So you could fit them into a small room. Today, to organize regional committee, we have to make provisions to ensure that we have seating capacity for 250 to 300 people. And at the global level, if you look at the EB room in the 90s, I have not participated, but I have seen pictures where EB meeting is only amongst the 34 members and then the WHO Secretariat and a few key partners there. Today, if you look at the EB room, you barely have seating places, both up in the gallery, and they even set up annex rooms with TV screens so that participants who cannot fit in that room can watch there. The point is that there are now so many who are interested in health that the discussions of health needs to include all of them, and therefore, by necessity, I think global health diplomacy has taken center stage. So the range of health issues that transcend national boundaries and require actions at the global level. The broad range of political, social, economic implications of health issues have brought diplomats into public health and public health experts into the world of diplomacy. With multitudes of agencies, each with accountability to their constituencies and with their own agenda, coupled with global health agenda largely driven by smaller groups of rich countries, whereas the important health issues are largely in the developing countries, it is all the more important to build global health diplomacy capacity for all member states. Next, please. So, sorry, can you go back? Yes. Yeah, sorry. Next, please. Yeah. So, realizing this importance as early as 2010, the regional committee in Southeast Asia passed a resolution on global health diplomacy. And the resolution called on member states to establish policies and programs for capacity building in global health and called upon the regional director to support member states by organizing regional training courses in global health. Next, please. So following this, Thailand took the lead in organizing or taking the lead in organizing such trainings. And initial few years, WHO supported this, both financially as well as making room to have such a training on the sidelines of our briefings for EB and our briefings of World Health Assembly, which we organize for our member states here. And then I think in the last few years, Thailand has now been working on a bilateral basis with countries, and some of the countries have been actively taking forward such trainings for their own participants. One of the important emergence out of this global health training is the concept of what is called regional one voice, and that is where the member states come together to agree to identify one speaker who would speak on behalf of the whole region. And that came to be known as the Regional One Voice. Next, please. Now, in the EB as well as World Health Assembly, you will see there are many blocks, whether it is EU, whether it is the African Union, and there are many others like the Scandinavian bloc. So everybody makes a statement on behalf of a particular group or a bloc, and then of course on behalf of their member states. So we do the same. And at the EB, of course, it is the EB members who have the who make such statement. But since the EB members are there as experts on their own, uh, uh, the Regional One Voice is not that important there. But in the World Health Assembly, the Regional One Voice is very important. And in the past few years, CRO has done very well. And CRO's contribution to the discussion and the decisions of the assembly on various agenda through the Regional One Voice has come to be appreciated greatly. Next, please. So today, the actors that shape the global health governance are far more than just WHO member states, as I said. So we have, private sector, civil society, association, foundations, and of course, the member states. And in the clamor of voices of many groups, it risks losing the member states' voice in shaping global health agenda, which eventually impacts countries. Eventually, health problems are in the countries, and it is the countries that must solve the problems. And therefore, if our member states do not build the capacity to be able to have their voices heard at such huge global meetings, then we risk losing our interest in that. And therefore, increasingly, global health agenda is often driven by donors, rich countries, deep-pocketed interest groups, and may not necessarily reflect or decisions made by global groups may not necessarily be of interest to our member states. Next, please. So in this, global health is important because in the increasingly complex interplay of politics, economics, and changing social and environmental milieu, the discussion on health issues span beyond the normal skills of a public health expert. To fill this gap, most countries have health attaches because now discussion continues in Geneva all the time. And the WHO headquarters always invites the embassies located in Geneva to participate in that. Now, the countries that can afford it have health experts sitting in their embassies as health attaches, and countries that don't have their career diplomat filling that gap. So the dilemma in doing this is that often for many of our countries, we have diplomats with no public health expertise, or sometimes we have public health experts with no diplomatic skills or training in that. And therefore, um, to have both skills and have such persons for most of our countries, I think still is a big challenge because countries cannot have very large embassies in a place like Geneva. Next, please. So although there is this awareness, and in some of the countries, like big countries, especially like, let's say like India, and I'm sure even in Indonesia, I mean, we do have people who are medical background or public health experts who then go into diplomatic trainings, or diplomats who have such technical background. But this is pure chance and fortuitous, I would say, and not a systematic and a planned approach to that. Sorry, yeah, thank you. So, and also, if you look at the major public health schools in the West, whether you're talking about the London School or whether you're talking Hopkins, Harvard, everywhere, they all provide global health leadership courses. But I think in our region, the universities, I think, I am not sure if any universities in our region have well-known such courses in their programs. And if there are, I would say that we need to work harder to make them more accessible to more countries. So in many of our countries and our regions, public health and public health experts are not often seen or seen as important as clinicians, and therefore the focus on public health usually is not as much, and therefore the will and the effort to build a capacity does not necessarily become a strong focus in the member state. And I think this is a challenge that needs to be tackled. Next, please. So, despite the many challenges, I would say that there is no better time than now for global health. As I said, we have huge organizations that are pumping billions of dollars into programs in many countries. To give you an example, in 1989, when I became the malaria program manager, for 1 year from WHO, I had a budget of $15,000. Today, same program is receiving millions of dollars. So in terms of the resources today, there is so much more resources available for various health programs and for public health. And then with the current pandemic, there is a very strong global will to generate more resources, and there are billions of dollars, particularly to deal with this pandemic. And we are already pushing hard that not only just deal with this pandemic, but we have to build stronger and more resilient health systems for the future. There is now global consensus that health is central to progress and development, and therefore donors are more willing to invest in health. Next, please. So uh, uh, in the decade as we move forward, the nature of 21st century health calls for a radical change of mindset and recognition, or a reorganization of how we govern health in the 21st century, as said by Professor Kickbush from the University in Geneva. So today's health ministers have a dual role, and I think when I talked about public health going into diplomatic and diplomats coming into public health, I think even our health ministers face a dual responsibility, that is to promote his or her country's health and at the same time to advance the health interests of the global community at large. Next, please. Therefore, what we should do to take forward this agenda in our region, as I said, with leadership from Thailand and support from WHO, we have initiated the training in global health leadership. I think what we need to do is that we have to build our region and regional capacity for more training, so that on a systematic and regular basis, we could do that. We have to create for our future health leaders the opportunity to engage at regional and global health forum and in global health governance discussion. National governments need to relook at their HR policies and practices to redefine the roles of public health experts and build stronger linkages with ministries of foreign affairs through mutual collaboration and mutual capacity building. Next, please. And last, I would like to leave a reflection from Varinen book on globalization and global governance. Basically bringing the focus that no matter what happens at the global level, eventually it is at the country level that things happen. And it is at the country level that we have to build the capacity to be able to deal with the health issues and health problems of our region and our countries. Next, please. I think next is, yeah. So I was asked to post some questions. So I will leave this three questions up here. And I would like to thank all of you for listening to my talk.
Thank you, Dr. Pam, for your very comprehensive presentations. It can make a broaden our mind and our participant how important it is the global health leadership. Yeah. First of all, I'm very glad to see you again virtually. Yeah. Yes, it's been a long time for me not to Delhi. Since the last RC, yeah, taken by virtually due to this situation, current conditions. Yeah. You have already reached about some issues. There's so many issues that you have been reached about the roles of global health leadership, global health governance, and then the paradigm shift. Yeah, in the last decade. Yeah, from national become more global, international. Yeah, and then you have also described the roles of WHO in the global health governance. So actually global health governance beyond WHO. Yeah, and then you already give experience what the WHO have already did to assist the member states to increase their capacity, yeah, especially in global health governance, yeah. So I would like to open the floor for discussion, yeah. As you may already see at the chat box, there is a questions from Mr. Rahbudi, yeah. Please explain more. Yeah, please explain more. Detail the meaning of the resilience leadership and what kind of the model, for example, that we can follow. Yeah, Mr. Pan, please.
Yeah. Okay. Thank you. Thank you for the question. I think the term resilient basically means strength, and I think what it means is that when we are building systems, we need to look at build a system that can withstand pressure. To give an example, we have now since the end of Second World War and the establishment of WHO, I think countries have spent a lot of time on building health systems, and we talk a lot about health system. But one thing that came out very clearly with the pandemic today is that many of the systems that we thought are okay are unable to withstand the pressure put by the pandemic. For example, many of our countries have now realized that uh, in the effort to deal with the pandemic, and we have to repurpose the health workers and related workers to deal with that, and the hospitals as well to meet with that. And as a consequence of that, what we are seeing is that the essential services that should be available throughout, for example, for people with chronic disease needs, let's say a diabetes person or a hypertensive person or person requiring cancer treatment, or mother and child health that antenatal services as well as postnatal services, these services need to run. And we found that WHO carried out a very quick survey in March, April, and found that in some of the countries in the initial months, there was a total shutdown of all these services. And I think now countries realize that that is not a way to go, and therefore are now trying to come back. But because I think our systems are not built strong enough to withstand this kind of shocks, that we realize that when we are stressed, we often lose out on the larger thing, because in the end, and we have seen this with Ebola, when Ebola outbreak occurred in Africa, the effort of controlling it was such that it demanded everybody to deal with that. And of course, Ebola killed hundreds of people. But later on, when they looked at, they realized that actually there are several times more children and people have died from normal diseases and others that could have been prevented through the normal services, had the health system been strong enough to deal with the epidemic at the same time continue. So in future, building a resilient system, we're going to have to look at how to build a surge capacity to deal with emergencies such as the pandemic, and to ensure that the basic essential services can continue in a systematic manner as it should be. So I think that is what is meant by resilient systems when we talk about that. Does that answer your question?
Ya,
Yes,
Para
thank
Budi.
you, Dr. Pam. Thank you. Your explanation is very detailed and understandable. My question is based on the art of diplomacy because as you answer, your answer is resilience means strong or strong. It means like a tough diplomacy that we not easy to change or receive another option or another opinion. So from your answer, I can more understand about that. Thank you very much, Mr. Pham.
Yeah, I would like to add that. Yeah, okay. I think there's some background thing.
Bu Evelina, kalau bisa di silent Bu, ya, makasih.
Yeah, yeah. So I think I think resilience does not necessarily refer to diplomacy. I think we need to look at this slightly differently. I think the point that I was trying to make was what we have today is because you have so many players in the health arena, health issues become basically a negotiation issue. And if we do not have health experts who have negotiation skills and I would say the art of diplomacy, I think we would lose our interest to the ones or the groups that have such expertise and skill. And I think that is the core of or the challenge that our countries face in having health experts or diplomats with health experts or health experts with diplomatic and negotiation skills. And I think that is what we need to build in our countries.
Okay, thank you, Dr. Prem. I think it's related to your number one question at the end of your presentation that we can choose is it a public health practitioner and then train as a diplomat or diplomat uh, train as a public health professional. I think from your answer, I can guess the answer is related to likely. Likely is number one, the option one. It means it's easier for us train the public health professional like us all here as participant, and we are well trained as a diplomatic. Thank you very much.
Yeah, I think the question that question is for the participants to give your reflections on what do you think is a better option. Yeah. So I think Pabudi already gave one option as perhaps better, but others may have different opinions on that.
Yeah, I think we can elaborate more that the question that has been raised by Mr. Pam at the discussion later on this afternoon, I think. So I think the global health diplomacy workshop that we have already that we are still going on right now, I think is to create health expertise with the diplomat competencies. Yeah, so I think it's gradually and need time, yeah, to increase our competencies actually. So the next questions, yeah, I see the question from Mr. Budi Harja, Dr. Budi Harja. Dr. Pam, would you like to have your comments in the global health leadership of the WHO country office in shared countries so far? As I understand that the WHO reforms should be based on the WHO country office's competencies. What do you think about that?
I mean, yeah, thank you for that question. As I said, WHO is a secretariat to the member states as a institution. But WHO's role is to provide countries the expertise and technical support in health and the normative functions, that is the standard settings that WHO normally does. And therefore, given that centrality of that role, of course, strengthening or having a strong presence of WHO at the country level, I think is very important. And you are absolutely right. WHO reform looks at how to strengthen countries and country presence. And the current WHO General Program of Work, which is called GPW 13, puts that very squarely in its mission, that it is countries first. And therefore, we are looking at how we can strengthen country presence. Now, just to for many participants who may not be familiar with how WHO works, if you take our region as an example, uh, all our countries, 11 member countries, have WHO country offices. And if you compare our WHO country offices in the region with, let's say, WHO country offices in some other region, let's say Africa as an example, in terms of the presence of WHO and capacity at the country office level, we are already, I would say, quite well established in almost all our countries. We have big presence, for example, in Indonesia, in India, in Myanmar, in Nepal, and even in small countries like Timor and Bhutan and Maldives. We have relatively strong presence because we believe that at the end of the day, it is the countries that need the support, and we have to be there near to the countries to work with the ministries on a day-to-day basis to support the government in their work. So certainly, I think focusing on countries is very important. Our region, unlike any other region, from whatever budget that we get for our biennium, which is our 2-year work plan, CRO is the only country where we ensure right from the beginning 75% of allocation of that resources to the countries, and less than 25% is used in the regions. Even what is in the region, most of the work is carried out in the countries or to support countries. For example, participants coming to meetings that we organize, or global meetings. So we actually spend maximum last year, last biennium, I think we had spent almost 87% of the money that we have in the countries. So for us, the focus is countries, and that is where we are doing our best to strengthen. And now, at the same time, the dilemma is, one is to have WHO's presence and the technical experts there, and at the same time, we also provide monetary support for activities in the countries to the ministries of health. Now, today that comes in two ways. One is that there are specific programs that generate money. I mentioned about Gavi, I mentioned about Global Fund, although Global Fund doesn't provide money through WHO, but other donors do that. And therefore, the pot of money that we use is a mix of what we have as WHO's own money, which is contribution by member states as what is called SS contribution, and then in addition the donor money, and we put that together and then we provide that back to the country. Actually, if you look at the basic concept of why the SS contribution, if you go back to the origin of this, and the constitutional basis of this was that the SS contribution is contribution by the member states to enable WHO to do its work to support the member states. But we are actually giving a large portion of that money back to the member states for activities in the country. So for us, the country is center, and we are making sure that whatever resources that we're able to generate, that the countries benefit maximum out of that. So.
Thank you, Dr. Pam. Yes, I would like to acknowledge that this workshop could be materialized also because supported by WHO. Yeah, Dr. Budi, sorry, Budiarja, Dr. Budiarja, is there answer the questions, Pak Budi?
Okay. Okay, thank you, Pak Fer. I think it's quite clear about the comments from Dr. Pem Nagyal. Please correct me if I'm wrong, Dr. Pem. As far as I understand, there is based on the WHO constitution, it has some kind of a mission that is to coordinate all the international partners in the country. So based on this, it is related with the leadership actually. So what do you think about how WHO Country Office in the share countries already have this kind of mission accomplished? Thank you very much. It is another additional question actually, Pak Ferdinand.
Yeah.
Thank you.
Okay. Thank you for that question. So as I mentioned in my presentation, one of the comparative advantages of WHO is its convening power, and that is what is at the center of WHO's work, whether it is at the global level, regional level, or even at the country level. And in the countries, we have WHO representatives in all the countries. And in all the countries, our WHO representatives play a very key role in facilitating or coordinating amongst the partners. Now, of course, there are some variations depending both on the skills and capacity of the WRs as well as the willingness of other partners to engage in such things. But we certainly put partner collaboration coordination as the center of our work in the countries, because we acknowledge and we are very conscious of the fact that WHO alone is not the player in the country. In some of the countries, there are donor partners that are far more important, and therefore we make sure that we link with these and facilitate the work of each other. But WHO is also very conscious, and we make all that effort to ensure that the international community at the country level accept or realize that that WHO's role in health is very important, and in all the countries we have always had very good working relations with the international agencies and partners in that. And today, with the new resident coordinating system, I think health has become central to the whole UN's work in all the countries, and our WRs work very closely with the RCs on health issues and in supporting countries on that.
Okay, thank you very much, Dr. Pem.
Yeah. Let's continue the questions. I see at the chat room from Dr. Imran Pambudi. The question is how WHO can play the role to put neglected issue back to spotlight. Is it dependent on member state?
Well, so yeah, thank you for that question. I would say it's both. The WHO's normative function, as I highlighted, is generating evidence, tracking disease trends, and providing the leadership in that. So therefore, if WHO sees through its, let's say, trend analysis and disease monitoring, if it sees that there is an important disease, or if there is an important health issue that is coming up, WHO can certainly take the lead on that on its own. But at the same time, countries play a very important role. And as you know, as a process for the governing body meetings, whether it is the RC, whether it is the EB or the World Health Assembly, the agenda generation starts from the countries. And Indonesia, for example, has been very active in this one. And has raised in the past many important key issues. The most recent being, for example, eye health. Bringing it to the regional committee discussions. So this I would say it is both the WHO by itself, but primarily the countries bring up the issues, and then if it merits discussion then it rises to the regional level. And if it is of global significance, then it will rise to the level of the global governance discussions.
Dr. Imran, is there answer your questions?
Yeah, Pak Ferdi, thank you. Thank you, Dr. Pam, for your explanation. So maybe I just want to have a comment that sometimes the issue that brings or came from the small country sometimes is not uh, have the good response to the international event. So I mean that how WHO can respond that small issue like neglected issues that I mentioned. So it will be bring to the more equity. Thank you, Dr. Pan.
Yeah, I mean, as I said, as far as WHO is concerned, all member states are equal, and we pay equal attention to all member states. So if any member states brings up an issue that we think is important, certainly we would support that. Now, it may happen that when a issue is raised, which may be local, and if we try to raise it at the international level, as I said, given the multitude of players and the many issues that needs to be discussed at the global level, yeah, sometimes some of the things may fall through the cracks. But I think again, countries have to bring that up to the attention of the governing bodies. I think in WHO we certainly have a very strong focus on small countries, and again within small countries there are groups of what are known as small island countries. For example, in the Western Pacific region, there are many Pacific island countries that are very small, and likewise in our region we have Maldives, we as an island, small island country, and we have small countries such as Timor and Bhutan. But in our governing body discussion, no country is treated different from any other country, irrespective of the size.
Okay, Dr. Imber, I think it can be satisfied your questions. I would like to continue the questions. We still have 25 minutes left because we will finish this session until 10:45. I continue with the question from Sarah. Yeah, Dr. Pam, your statement on the fact that public health practitioners do not have the same recognition as our colleague with medical background in the global health arena. Do you have any suggestions on how to increase the recognitions for public health practitioners in the global health arena? And what capacity that we need to strengthen?
Yeah. So let me correct that first. When I say public health does not have equal recognition, it is at the country level, and that is the root cause of the problem, because of that, countries don't invest really in building the capacity of the public health experts in the countries, or to build public health in the countries. And when the discussion then rises to the global level, we do not necessarily have people with the necessary background and skills to be able to deal with and negotiate as appropriate at the global level. So that was the point that I was trying to make. In many countries, I think public health, when a doctor goes into public health, people often think that public health is just general administration. They do not often see it as a specialty by itself. That public health is a specialty in itself, and that just simply having a medical degree is not enough. You have to train people in public health to be public health experts. But I don't think in many countries that kind of attention is given, or appreciation is given to public health expertise as opposed to a natural appreciation of the clinical work in that. So that was the point that I was trying to make. But in terms of building the capacity, I think I would say we have to work at the country level. If we build a core group of public health experts and build their capacity even in negotiations and diplomacy, then naturally these people would represent the country at the global level, and therefore you would have that capacity of both public health expertise and diplomatic skills at the global level. So I would say that it is at the country level that we need to focus on building that capacity, because if we do not do that at the country level, we cannot have it at the global or regional level.
Sarah, do you have something to clarify or to add?
No, actually, so I think what Dr. Pam has explained, I think is already answered to questions. Thank you, Pak Ferdi.
Okay. We continue the questions. I have two questions left in my chat box from, is it from Pak Himawan? Yeah. Dear Dr. Pam, I have two questions to seek your insight. First, what is the difference between rules, examples, FCTC, IHR, and resolutions in WHO governance? Do those two have different consequences for member states? And the second, did multinational pharma manufacturers involve or had a role in the governing global health? What is your experience on this?
Okay, so on the first question, sorry. So what is the difference between rules, that is between FCTC and IHR? In principle, these two are the only legally binding instruments that WHO has. As you know, all of WHO's recommendations, or for that matter, even WHO World Health Assembly resolutions, are not legally binding. Countries may agree on a consensus to pass such a resolution, and countries are encouraged to take forward and implement it, but it is not legally binding. But for the FCTC, which is the Framework Convention on Tobacco, it is a legally binding instrument. And likewise, the International Health Regulation 2005, which is the second revision. I think the first one is 1969. So the IHR 2005 is also a legally binding instrument. Having said that, of course, WHO has got no, I would say, enforcing capacity, and WHO does not see itself as an enforcement agency. It expects the member states to bind when it is legally binding. I would say to bind themselves to the provisions that they as member states have agreed to. So therefore, in principle, the IHR and FCTC are legally binding instruments. Of course, the provisions and purpose of the two are for different purposes. One is purely for tobacco, and the other one is more broad-based international health. That is the difference on that. And the question says, do these two have different consequences for member states? Because they have different, they are addressing different issues. I think the requirement by the countries are different for each of these. For example, tobacco. Of course, tobacco has got big consequence for the countries. If you implement all the regulations related to tobacco, then first of all, tobacco industries, big consequences on them. But the bigger consequence for the countries is that if countries successfully implement the tobacco framework convention, then we would have a significant impact on public health and diseases associated with smoking. So that is the direct benefit that countries would have, and the indirect benefit would be the economic benefit of having a healthier population, having less disease. Of course, it may lead to some degree of loss of tax, and it may lead to some people becoming less rich, and that is why we have so much resistance in implementing the Framework Convention on Tobacco in countries. And IHR, while member countries realize that IHR is very important and key to that, yet we do not see sufficient investment and effort by member countries to really implement all provisions of the international health regulation. Now, on the second part regarding multinational and pharmaceutical companies, as I said, today, health governing body meetings is a broad-based, open for all kind of discussion. So at the discussion level, certainly the pharma industries as well as multinationals have a voice. As you know, in the EB as well as in the World Health Assembly, they are usually represented not as individual companies, but they come as a group, and the group representatives do have a voice where they make statements on the various agenda items. Of course, WHO is very keen to ensure the conflict of interest is taken care of in all that we do through the Framework Convention on Non-State Actors called FENSA. And we make sure that we do not allow either pharmaceutical companies or other companies to attain a edge on the discussions and the prioritization in WHO's work. Therefore, even experts that we recruit onto any groups that WHO takes, now we require them to submit a declaration of interest to make sure that they are not being paid by a company, or they're not receiving, or they're not doing work for a particular company or otherwise, which may be perceived as having an undue advantage. So to manage the conflict of interest is very important, because WHO needs to ensure that we stay independent. WHO needs to make sure that our guidance is purely based on evidence and is not pushed by interest groups. So that is what we strive for.
Pak Himawan, anything to clarify? Is there satisfied with the answer?
Yes, thank you, Dr. Pam, Dr. Ferdi. It's very concise. Thank you.
Thank you.
Yes, thank you. So I have one left questions, yeah, from Ibu Anna, yeah, Husrengun. Dear Dr. Pam, this ongoing pandemic also put WHO at the center of criticism on how to effectively handle the situations. In particular, a country leader declared an intention to quit WHO. What are WHO approach to address this issue, as it is important to engage every leader country, every leader working together in this global health issue?
Yeah, so thank you for that question. I think this comes back to the center of what I was trying to highlight. Today, the discussion of health is no more just health. I would say today, health is very central to political discussions. And unfortunately, in the current scenario, and I can say it openly, in the current scenario, due to the rivalry between the United States and China, rightly or wrongly, have put a lot of attention on, I would say, issues that should not be an issue, but has become an issue. That is the unfortunate aspects of globalization and global governance, and the challenges that we face when you have political interests that override health interests, and we land up in situations such as this. And linked to that question was the US declaration that they want to leave WHO. Now, as I said, WHO is a member state organization, and the constitution of WHO allows a member state to leave WHO if they so desire. Of course, WHO's desire is that no member state leave, and we are very keen that United States stay within WHO not only because they are a very large contributor, they contribute almost 21 to 22% of our budget. Not only they are a large contributor, but United States is also technically a very advanced country where innovation is there all the time, and where we have many experts in health, where there are many institutions and academic centers of excellence, which we want to be part of for the benefit of the global community. So we are very keen that this does not happen. But it is not within WHO's power to prevent member states if the member state so desires to leave the WHO. So we are at a crossroad, I would say, that we still desire that no member state do this. But if a member state insists on doing this, then I'm afraid WHO will need to adapt to that reality and see how best we can continue to work with the rest of the global community. Even if a member state leaves the WHO, as far as I see, I do not see WHO looking at that particular state as not a part of the global community. We look at all peoples of the world as part of the global community, and therefore, even if at the political level it is not a part of it, I think at the individual and personal engagement level, we would look at it still as the same global community.
Ibu Ana, is that satisfied
Yes.
or answer your questions?
Yes, I would like to know whether WHO also maybe like convene a dialogue between WHO and also with the country. As far as I know, maybe not only the US, maybe Brazil as well. So maybe there is a kind of strategy from the WHO to try to communicate with those countries to clarify or maybe to find a solution before they clearly making a further step to leave the WHO.
Yeah, thank you. I can assure you there is furious activity behind the scenes, going on to try and discourage countries from doing that. So no, WHO is not sitting idle. There is a lot of work going on behind the scenes, engaging with these countries and discussing with them on how best we can serve the interests of the global global health in this.
Thank you. This is something that we need to know. That WHO is just not stay quiet. Thank you.
Thank you. I see no questions in the chat box, but actually we still have 9 minutes left. So let me raise my questions, because this is a very important sessions that we rarely happened. Because the virtual, we have a benefit actually, we can invite the speakers across the regions, yeah? We have from Duke University, United States, and then last week we have from Thailand, and this week we have from Seattle. So I will use this moment to continue the questions from Ibu Ana, yeah? I personally appreciate the leadership of WHO in this pandemic, yeah, current situations, even though there are some countries doubt about the leadership and the independency of WHO in managing all interests of its parties involved. Yeah, actually, WHO has regulate some of it. There, you already mentioned a multitude of stakeholders in global health governance. By, for example, make the FENSA framework engagement with non-state actors. Yeah, there's the resolution adopted. So in last WHO also there is a request, yeah, from the member states to review how WHO to respond the pandemic. Yeah, maybe you still remember there is a team that already established called IPPR. Yeah, then actually it's related to the implementation of the IHR, yeah. How WHO respond when the pandemic happened, yeah. So I would like to recall when at the beginning countries, yeah, and at the outbreak in Wuhan happened, countries competing each other to evacuate their citizens, yeah, to save their citizens, that actually it could spreading the virus, yeah, it could spreading the virus. If they trust the China to maintain the condition of outbreak, maybe they let the citizens there and it could be contained the city. So there is one of, I think, break the law of IHR that, as you mentioned, is legally binding. The member state is not stick or obey the rule of IHR, although it's already mentioned that it's legally binding. So my questions, is there any punishment sanctions, yeah? For examples, not only the sample that I'm told, for example, the country is trying to hide the new virus transmission erupted, yeah, or late to report to WHO, yeah, because I never see the country bring to international court or justice because broke the law of IHR, of FCTC, for example, yeah. So you are talking about the health expertise, you are talking about diplomat. My questions, is it possible for WHO, yeah, to engage international lawyer, yeah, to discuss about this sensitive issue, yeah? Some countries need transparent investigations because they are already got impacted, massive impacted of these current situations, yeah. Because you know, some big countries, maybe they have the right of veto in UN, and then can make anything that they want. So this is my overview, and maybe you can give the some uh, explanation about that.
Okay. Yeah, so thank you for that question. I think those are very important question, and I would say difficult issues that you raise, and the issues that face countries. First of all, there are actually two committees now concurrently working. One is the international panel that was created to evaluate WHO's response to the pandemic, which is led by Helen Stark and Elizabeth Sirleaf. And they have identified, I think, 11 panel members, globally renowned people to be on that, and they're looking at that WHO's response to pandemic. So that's one stream of work which was mandated by the World Health Assembly for WHO. The other one is the International Health IHR Review Committee, which has, I think, 21 members, international experts, and they are currently reviewing the IHR 2005 to look at how we could strengthen that. So these two activities are going side by side. Now, with regards to can WHO enforce it, and as I said, I think, you know, although these are legally binding instruments which should be enforced, but WHO as a secretariat to the member states does not have enforcement authority. I don't think WHO can take any country to court or enforce these. WHO can encourage countries to bind to the provisions of the treaties that they signed up to. So I think that is the maximum we can do. Now, the other component which you touched, which was in the event a country is hiding data or information, I think certainly WHO has a role in that. And I think we try our best to try and obtain information as early as possible. Even in this pandemic, if you look at it, it was the China country office that immediately alerted as soon as this strange fever outbreak was reported in Wuhan. And then, of course, immediately the Chinese government, using the IHR provisions, reported to WHO. So certainly, I think where countries are not being sort of upfront of a potentially dangerous outbreak, WHO can call out a country for not doing that. But WHO again, as a secretary to member states, we make sure that we always work through the government and with the government, because at the end, what we have to do is try and control and contain this. Now, with regards to individual countries' reaction, you see this every time you have when Ebola occurred. You would recall countries started closing borders, stopping all flights, and then same thing happened when this corona outbreak occurred. And with regards to the evacuation, I mean, I fully agree with you that it was a perfect way to spread the disease. For example, take Bhutan, a small country. We also evacuated a lot of people from abroad, and now, as of now, we have something like 200 plus cases, and all of them, almost all of them are, except for I think 8. Almost all of them are in people that came from the Middle East or evacuated from Middle East. So likewise, I think countries did face that problem, but I think evacuation became a political exigency for the political leaders, because I think if when one country started, the political leaders of other countries were under pressure by their own country to do the same. So I guess it was inevitable. But having said that, what I would say is that rather than press for banning such things, I think what lessons I would say we take forward on this is that we have to build our capacity in the countries for surveillance, for rapid response, and for immediate management of cases when you identify it. I think my personal reflection is that in some ways, I think we have sort of made this coronavirus look like it is some sort of a monster, and we built the hype around it so much that people are so afraid of this. But if you look at the data and you look at the mortality on this, common flu, which is now starting in northern hemisphere, probably kills more people every year than corona has done so far. But because it is a pandemic, and because it was made to look so dangerous, that there is, I would say, an overreaction from the countries. And if you go back to how we dealt with public health issues, you look at smallpox eradication, you look at polio eradication. The strategy was to identify, to isolate, and treat, so that you build strong surveillance system, you build rapid response system, and you build a quick separation of cases from the population, not put the whole population under lockdowns. So I think there are lessons to be learned from the way we responded to this pandemic. And I think perhaps sometime in future, the global community would sit together, look at it, and see what are the lessons that we can learn from the pandemic as we go forward, and learn in our region. Let us look at, let's say, Thailand as an example. I think Thailand is a very good example of a very strong, resilient public health system. Is an example of a public health response based on data, based on information, and based on scientific guidance to the political leaders. And yes, they suffered the impact like any other countries because of the lockdown, the stoppage of flights and others. But in terms of managing the pandemic, I would say in our region, Thailand, Sri Lanka, these are countries that have done really well in dealing with that. And it is because of a very strong public health system in place. And it is because the political leaders were willing to listen to the experts on how to manage this. And therefore, I think we have to strive in all countries to build that capacity and to build that system so that next time we would be able to do better than we have in dealing with this pandemic.
Thank you, Pak Pem, for your very comprehensive answer. Actually, we are running out the time and have to say sorry to Ambassador Sunu that already there. Sorry, Ambassador Sunu, because I still see the Professor Adik would like to raise a questions. Prof. Adik, are you there?
Yeah, I'm here.
Yes, please, 2 minutes.
Yes, no problem. I will make it quick. First, I'm so happy that I can see Dr. Pam again, and that reminds me of the old good days in Seattle. Number two, Dr. Pam, my question is very straightforward. It's not about the content, but it's about the global health diplomacy capacity building. And you mentioned that Thailand has already done it for years, and also I know in Geneva there is even an institute. My question to you is, what are the components most that we have to take when we are going to continue this kind of global health diplomacy training, as what you said, to improve us to be empowered so we can be skillful, we can also be out front when we come to the negotiations and diplomacy at the regional and global level. Thank you very much, Dr. Ferry.
Okay, thank you, Professor Adik. I think I would say there are two aspects to this one that we need to look at. The first one, of course, is to have our young generation or our public health experts trained in public health and ensuring that they stay abreast of the changing situations of global health as well as public health in general in your own country, so that they are conversant with the issues when they have to talk. Linked to that, I think, is that in this training of global health, what we have done till now is essentially sort of train people to be aware of what are the key health issues and what sort of discussion is happening around that and what are the pros and cons on that. I think the next step to that we have to go, as I said, is that we have to train our public health experts or our diplomats who have negotiation and diplomatic skills. If we are not able to get public health people with diplomatic skills, we have to train them. But I think investing in diplomatic and negotiation skills for public health experts, to me, it would be a cheaper alternative because to train a public health experts requires 5 to 8 years of training to be in that, and then many years of participation in such forum. Therefore, I think an element of diplomatic skills and negotiation an element of diplomacy and negotiation skills should become part of the global health leadership training.
Thank you.
Thank you. Our speaker, Dr. Pam Namgyal, is very. We are very lucky to have you as a speaker in our global health diplomacy, and I would like to invite all the participants and facilitators give the applause to Dr. Pam. Thank you very much.
And from my side, once again, thank you very much for giving me this opportunity. It was a great pleasure. And I hope that the discussion was of interest to all of you.
Yes, of course, you are still. You may still continue this to see another presentation if you may.
Yeah. Okay. Thank you.
Thank you. Yeah. Okay, dear participants. Due to we are out of the time. Sorry, we have a limit over the limit. I don't make any conclusions. What in the first presentations, I believe you already digest all the presentation made, and then have a better understanding now about the leadership of global health diplomacy. And now we are very lucky here because I see His Excellency Ambassador Sunu Mahadi
Pak
Sumarno.
Ferdinand, selamat siang. Good morning.
Good morning.
It's good to see you again.
Yes.
Saya tidak tahu ada siapa saja, tapi salam kenal untuk Profesor Adik. Saya kira Pak Dr. Budi, Dr. Budi aja juga saya kenal dulu ya. Saya tidak tahu ada siapa lagi di situ, tapi terima kasih atas undangan ini ya. Thank you for the invitation to speak on this very important topic, health diplomacy. So I was asked to speak on this, and Pak Ferdinand permit me to just start my presentation if you agree.
Actually, I would like to introduce you,
Pak.
Oh,
yeah.
Yes.
Sorry, yeah.
Because
please.
some participants may not recognize yet. So allow me to read the curriculum vitae of the Ambassador Sunu Mahadi Sumarno.
Right.
Yes. Born in Bandung, 20 August 1958. Yeah. Ambassador Sunu graduated from Faculty of Social and Political Science, University of Indonesia, with a bachelor degree in international relations in 1985, and from the Faculty of Law, University of Wollongong, New South Wales, Australia, with a master degree in the international relations in 1991. He joined the Ministry of Foreign Affairs in 1986 and initially served within the Center of Political Affairs at the Ministry Agency for Research and Development. Since then, Ambassador Sunu has developed a rich portfolio within the Ministry of Health, starting with the regional cooperation, bilateral relations. There's so many.
Ministry of Foreign Affairs.
Within the Ministry of Foreign Affairs. Yes, of course. And then Ambassador Sunu served as a director for social culture affairs and international organizations of developing countries between 2007 and 2012, during which he was Indonesia representative at the Global Fund. I think it's very relevant with health. His posting abroad, including position of political staff in the Indonesia Embassy in Seoul, and then Indonesia Permanent Mission in Geneva, and then ambassador at Indonesia Embassy in Nairobi, Kenya, also serving as Indonesia ambassador to Uganda, Mauritius, and Seychelles. Yes, as well as as UN bodies in Nairobi. Yeah. During his time in Geneva, Ambassador Sunu was in charge of WHO-related issues and supported Indonesia's health minister within health diplomacy. He was involved in negotiation on benefit sharing in the WHO, which was prompted by the controversy surrounding avian influenza that originated in Indonesia. During his posting in Nairobi, he was the chair of the permanent representative of UNEP member state and led UNEP meeting between 2014 and 2015. So he was participated in numerous international meetings. I do not read that. There's so many international meetings that has been attended. So without ado, I would like to give the floor to Ambassador Mr. Sunu. The floor is yours.
Thank you. Thank you, Pak Ferdinand. Well, my presentation, of course, started with an introduction. So over the last 2 decades, global health issues have become more prominent in foreign policy. The ongoing COVID-19 pandemic, previous Ebola pandemic, the HIV/AIDS, infectious diseases, the threat of bioterrorism, and issues related to trade and health have stimulated policymakers. As countries become more and more interconnected and as health-related increasingly become global issues, state health actors are forced to seek cross-border collective action and collaboration with non-state actors. The United Nations General Assembly also emphasizes that governments must pay attention to global health in their foreign policies and increase their negotiations and political interactions in this field. So what we can see during the last decade, during the last 2 decades, is the prominence of health discussions, health discourses in international multilateral fora. Previously, when we talk about health, we were mainly talk about health in a national context, right? But with the growing globalization, deepening globalization, cross-border dynamics, now at least half of the issues when we speak about health is global. Pandemic, infectious diseases, and other health-related issues which cannot be solved without collaboration with other countries, without collaboration with the international community. So this is one of the most important changes, that when we talk about health now, uh, more than half perhaps of health-related issues cannot be separated from the international dynamics. And that is one of the most important concepts in this health diplomacy. Now, next slide. What is global health diplomacy? I think, I don't know, I'm not sure whether I should speak about this because previous speakers have explained about this, but let me have a quick rundown. Global health diplomacy is the process of negotiating collective action for global health that can eventually lead to a new forms of global health policy and governance. Global health diplomacy could generally be divided into 3 categories based on the interaction of actors around global public health issues, which are 1, core diplomacy, which is formal negotiations among nations. 2, multi-stakeholder diplomacy, which are negotiations among nations and other actors that do not necessarily lead to agreement. This is multi-stakeholder diplomacy, not necessarily between governments. And 3, informal diplomacy, that is interactions between international public health actors and their counterparts, including governmental officials, NGOs, private companies, and the public. So this is multi-stakeholder diplomacy. Core and multi-stakeholder diplomacy in global health require the effective use of a delicate mix of technical expertise, legal knowledge, and diplomatic skills. Now, types of global health diplomacy activities. Next slide, please. Formal types of global health diplomacy activities. Formal bilateral and multilateral negotiations, such as those that take place at the World Health Assembly and other multilateral forums, and traditional negotiations between donor and recipient countries regarding official bilateral health assistance. For example, negotiations around the WHO Framework Convention on Tobacco Control, negotiations around the pandemic influenza preparedness that was initiated by Indonesia. And those are formal bilateral and multilateral negotiations. With respect to multi-stakeholder diplomacy, that often includes countries as well as non-state actors. For example, the examples are the Global Fund to Fight AIDS, tuberculosis and malaria, the Global Alliance for Vaccine and Immunization, and the 2017 London Family Planning Summit. Interactions between health actors from one country acting in another country, which includes the activities of official and semi-official representatives from donor countries acting in recipient countries. USAID, for example, has healthcare improvement project in Indonesia to strengthen the Ministry of Health's capacity to deliver quality TB services. And I'm sure many other examples along this line. Successful global health diplomacy requires the identification and engagement of important instruments and actors, as well as coordinated actions by various counterparts and stakeholders. Okay, now next please. Important milestones of Indonesia's health diplomacy. In 2006, Indonesia, together with Brazil, France, Norway, Senegal, South Africa, and Thailand, initiated the formation of the Foreign Policy and Global Health, FPGH. This initiative re-examined how global challenges and opportunities have transformed diplomacy in the context of foreign policy and global health. It was the FPGH Oslo Ministerial Declaration of 2007 that underlined the importance of integrating health issues in foreign policy priorities and explored how foreign policy can accelerate consensus building in high-level health negotiations. The FPGH is committed to dealing with key global health issues that has produced several resolutions at the UN General Assembly since 2008. So the FPGH forum, the FPGH countries met every year and to agree to submit UN General Assembly resolution since 2008. A broad set of diplomatic actors engaged in a series of formal and informal negotiations with representatives of the Indonesian government when the global community criticized our policy to refuse to share avian influenza virus samples with the global influenza surveillance network beginning in 2005. We were concerned that we did not receive benefits from sharing these samples, and this is another example of important health diplomacy milestone undertaken by Indonesia. At the WHO, the Indonesian government pursued a more transparent and fair mechanism for virus sample sharing framework on the principles of prior informed consent and benefit sharing for all countries. By initiating the formulation of draft resolution on pandemic influenza preparedness, sharing of influenza viruses and access to vaccines and other benefits. It was a long and difficult process of negotiation in Geneva until it was unanimously adopted at the 60th session of the World Health Assembly in 2007. That was the WHA resolution 60-28. It was then the 64th session of the World Health Assembly in 2011. Again, we urged the implementation of the WHA resolution of 60-8 by adopting the Pandemic Influenza Preparedness (PIP) network, sharing influenza viruses and access to vaccines and other benefits. The global health community, in particular the developing countries, praised Indonesia's action and acknowledged it as a bold and innovative tool for pandemic influenza preparedness that placed virus sharing and benefit sharing on an equal footing. Another significant example of Indonesia's role in the international fora is the involvement of the former President Susilo Bambang Yudhoyono in co-chairing the United Nations Secretary General's high-level panel of eminent persons on the post-2015 Sustainable Development Agenda, where health was one of the key issues discussed. And another example is the Global Health Security Agenda Forum. It was held in Bali in 2016. Indonesia is one of the steering group countries and chaired the Troika that year, 2016. Through the Global Health Security Agenda, Indonesia produces the development of a joint external evaluation to be adopted by the WHO to strengthen the implementation of the 2005 International Health Regulation, WHO IHR. Together with Vietnam, Indonesia is a leading country for the Zoonotic Diseases Action Package in that forum, and is a contributing country for the Antimicrobial Action Package. Lastly, in the framework of the Organization of Islamic Cooperation, OIC, Indonesia is the OIC lead country coordinator group for cooperation in the areas of medicines, vaccines, and medical technologies. The 6th Islamic Conference of Health Ministers meeting in 2017 appointed Indonesia as the OIC Center of Excellence for the development of vaccines and biotechnology. This appointment reflects trust on the world-class capacity of Indonesia's pharmaceutical industry. Now, those are only examples, several examples that I gather for the as examples of Indonesia's health diplomacy, but I'm sure there are many others. And from the examples, it's clear that all of those successes, all of those processes were undertaken by multi-stakeholders, by not only by one part, one ministry, but coordinated among various organizations. For example, the OIC Center of Excellence, it was the work of the Badan POM in cooperation with Kemlu and the pharmaceutical industry in Indonesia. So there are many examples like this where the health diplomacy was undertaken with the collaboration with the important roles undertaken by various ministries and even industries. Next, please. Negotiation, an important tool in global health diplomacy. Now, in a new era of global health diplomacy, the most important tool for decision-making is negotiation. Negotiating global health is not purely public health issues. It is accumulated by challenges in health with trade and intellectual property rights. Negotiation in the domain of public health is mostly driven by viewpoint of trade and industry arguments. So if we look into what happened at the multilateral level, negotiation on the issue of health, at international level, it is not merely technical issues of health. The linkage is very strong with trade and industry, so as with other issues. Intersections of health, trade, and legal issues creates its complexity and requires intersectoral coherence. Coherency lintas sektoral. Government sectors often pursuing different objectives and priorities, therefore strengthening coordination and synergy among different ministries at the national level is very important. Coordination at the international fora is also a must for a successful health diplomacy. The negotiation for the WHO Framework Convention on Tobacco Control, for example, was intended to strengthen global action against tobacco. It was, however, incorporated broader interests, not only health and trade policy nexus, but also human rights, environment, and custom issues. Pak Ferdinand, permit me to speak in bahasa Indonesia about this. Sebagai contoh ya, saya berada satu mobil dengan waktu itu Menteri Kesehatan Dr. Suyudi di Jenewa. Waktu beliau masih Menteri Kesehatan. Dan beliau akhirnya mengakui bahwa kegagalan penerimaan di Indonesia untuk framework of tobacco control ini antara lain karena kurangnya koordinasi, kurangnya diseminasi dan koordinasi berbagai level secara nasional. Jadi pihak Kemkes memasukkan itu sebagai agenda nasional, katakanlah demikian. Tetapi kemudian terdapat tentangan, ya, tentangan dari berbagai golongan, berbagai pihak. Sebagian besarnya karena tidak paham apa isi dari framework tobacco control tersebut. Sampai sekarang itu jadi masalah. Jadi ini bukan saya tonjolkan sebagai contoh bagaimana ternyata koordinasi bukan hanya perlu di luar, tapi di dalam negeri kadang itu juga penting. Dan ini bukan kesalahan Kemkes sebetulnya, karena situasinya waktu itu memang masing-masing kementerian jalan sendiri gitu. Nah ini yang ingin sekarang ini sangat perlu, karena makin tingginya isu-isu lintas sektoral, maka juga sangat perlu untuk koordinasi dan kerjasama lintas kementerian. Next is negotiation case, the International Health Regulation. I would like to use the case of International Health Regulation, or IHR, as an example because IHR negotiations were unique. It was a technical issue, but politically set up. As a background, the SARS outbreak in 2003 gave the urgency to the revision process of the IHR and led to the realization that an international public health emergency not only affects human and animal health, but also economic life and countries' economic development. In May 2003, the World Health Assembly adopted Resolution 5628, which established the open-ended intergovernmental working group to review and revise the international health regulations with a view to the adoption of the revised regulations at the 2005 meeting of the Health Assembly. It was an ambitious target. At the time when multilateralism seemed to be outdated, there was a political consensus that only a multilateral approach to dealing with an international public health could work. There was no sustainable counter-argument that no matter how robust a country's public health surveillance and support system, it was dependent on the effectiveness of the system in place in all other countries with which it had economic relations or person-to-person contact. Jadi bagaimanapun kuatnya sistem kesehatan di suatu negara, tetap saja negara tersebut akan tergantung dari sejauh mana efektifnya sistem internasional yang ada. Ya, karena globalisasi tadi, pergerakan lintas perbatasan, lintas batas. While political will is an essential ingredient to secure a successful outcome to any negotiation, it is not enough to ensure success. The pre-negotiation consultation process highlighted issues that would be at the heart of the discussions, including scope, sovereignty, implementation issues, compatibility with other international agreements, and trade. It identified the need for balance between measures to protect against the spread of disease and the need to maintain the welfare of the economic system. Among the outstanding issues during the IHR negotiation includes the issue of balance between the sovereignty rights of states parties, the role of the WHO Secretariat, and balance between effective science-based measures that would protect public health without placing unnecessary restrictions on international traffic. The issue of scope and how to define and determine the existence of a public health emergency of international concern. The core issue was to ensure that the IHR applied to naturally and non-naturally occurring outbreaks of disease likely to lead to a public health emergency of international concern. About on the issue of sovereignty, to be effective, the IHR had to ensure that the WHO was free from political interference. This was not immediately acceptable to all delegations, although there was no realistic alternative. Given the economic and other consequences, countries were concerned that there should be adequate consultative mechanisms in place to ensure that this authority was exercised with citizens. On the human rights issue, given the very wide powers to quarantine travelers, insist on medical examinations and etc., there was support for the inclusion of a strong reference to the need for the IHR to take account of broader human rights issues in their implementation. On the implementation issues, core capacity requirements were of particular concern to developing countries. On the one hand, the regulations would not be specifying the financial and other support that governments would receive to meet their obligations under the IHR. The IHR negotiation process. I think it's next slide. While the first negotiating session had gone beyond a number of areas, it was quite slow. The overall control of the negotiations was difficult because key negotiators frequently did not know their interlocutors. Other delegations consisted of many different areas of government who did not have a broader picture of their own government's overall objectives and of the process itself. In such cases, the role of the Geneva-based diplomatic missions in ensuring an overall coherent approach in national delegations was very important. The intergovernmental organizations saw themselves as important stakeholders in the proceedings, and their views would be important in ensuring coherence in the final outcome. The presence as observers of other intergovernmental organizations shows that some of the more difficult issues related to areas outside the health sector, including international trade and arms control. So, as you can see, the participation is broad-based. There are always political issues around the negotiation table, so delegations have to be clear about their primary objective. If we negotiate even on health issues, it depends on the level. The higher the level, the broader the position or the stakes for the country. So we go outside to negotiate. We have to know the national platform. What are the positions of our country? What are the objectives or the considerations that we have about this and that issue? So it's a national platform, negotiation on a national platform, not not only based on our ministry's own views. Now, when it was not possible to get agreement on the second or third or fourth negotiating sessions, small drafting groups are closely involved in the intersessional negotiation period. Jadi biasanya di antara meeting-meeting internasional yang besar itu ada waktu negosiasi, ya istilahnya intersessional negotiation. The drafting negotiation tried out alternative drafts to find a workable way to achieve a strong IHR. and to take account of the concerns of individual delegations and groups. Considerable progress was made, although the political problem remained of how to address non-naturally occurring events, which might constitute a public health emergency. Another development was the appearance, as the report of the high-level panel set up by the UN Secretary General produced a report entitled A More Secure World or Shared Responsibility, addressed public health defenses and suggests that the UN Security Council should consult with the Director General of WHO to establish the necessary procedures for working together in the event of a suspicious or overwhelming outbreak of infectious diseases. Jadi laporan high-level panel itu antara lain menyarankan bahwa Dewan Keamanan PBB perlu berkonsultasi, berkoordinasi dengan Dirjen WHO. Seandainya ada pandemi, overwhelming outbreak of infectious diseases. The text dealt with both the intentional release of an infectious biological agent and an overwhelming national outbreak of an infectious disease. Jadi saran tersebut dikaitkan dengan kemungkinan jadi seandainya ada wabah yang disebabkan oleh senjata biologi, atau ada pandemi yang sangat meluas gitu ya. From the perspective of the IHR negotiations, which were trying to get over 190 countries to sign up voluntarily to a legally binding instrument in this area, the threat of Security Council action was problematic. Jadi ini salah satu isu yang sempat menjadi masalah ya, dilematik, bahwa Dewan Keamanan akan ikut berperan di sini. Jadi banyak yang tidak setuju, banyak yang ragu-ragu. The final negotiation. Prior to the final negotiating session, the outstanding issues fell into three groups. The first group related to the treatment of non-naturally occurring outbreaks of disease. The second group related to additional measures, and the third to the final active. And the third group related to the final articles on entry into force and reservation. In addition, there were a number of loose ends to sort out. The negotiating process brought together legal, medical, and other experts, as well as representatives of international organizations and diplomats. Therefore, extensive interagency consultations back home is a must. What may have made the negotiation unique is that it is the elaboration of an internationally and legally binding agreement with sovereignty issue, and which could impact on vital interests across a broad range of economic, social, and political policies. At the same time, the IHR reaffirmed the fact that diplomacy is a unique profession. The negotiations would not have been concluded within the time frame without the active participation of Geneva-based mission personnel who helped to build the essential trust between delegations, to bring coherence to divergences in national and group positions, and to find ways of meeting the concerns of others. Jadi ada kita bisa melihat bagaimana luasnya, bagaimana cakupan lintas sektoral yang terkait, dan juga bahwa negosiasi ini memanfaatkan infrastruktur diplomasi yang ada di Jenewa waktu itu. Next slide, please. Strengthening health diplomacy. Understanding domestic issues in a regional and global context must be part of doing the job. The optimal solution to these issues will depend on what is happening abroad, and the solutions to foreign issues is by understanding what is happening at home. The recognition of the need for policy coherence, strategic direction, and a common value based in global health begins at the national level. A few countries, in particular in Europe, are beginning to address global health more consistently at the national level by mapping many activities in global health across all government sectors, establishing new mechanisms of coordination within government, and developing a national global health strategy, frequently at the initiative of the international department in the Ministry of Health. Next, please. Lessons learned from other countries. Switzerland has a joint strategic approach to global health that was developed by the Departments of the Interior and the Department of Foreign Affairs. They have a document called Agreement on Foreign Health Policy Objectives. Agreement on Foreign Health Policy Objectives. As the first of a number of special strategic agreements that the Department of Foreign Affairs is developing with different policy sectors within the government. This in itself is a significant signal of the change in diplomacy that is underway. The document brings together three major strands of global health action that run in parallel with little coordination or even in competition. These are the activities within the health sector that address normative health issues, international agreements and cooperation, global outbreaks of disease and pandemics, the commitment to health in the context of assistance towards development, and the policy initiatives in other sectors such as foreign policy and trade. It underlines the commitment of Switzerland to human rights and defines 5 priorities in foreign health policy, which are the health of the Swiss population, the coherence between national and international health policy, the strengthening of international health cooperation, the improvement of global health situation, and the strengthening of the Swiss commitment as host country to WHO and to major health industries. The second country, as example, is Brazil. Coalitions of developing countries as well as leadership from some of the middle-income countries such as Brazil have contributed to a significant power shift within global health diplomacy. The determining factor in Brazilian health diplomacy is the fact that in Brazil, health is a right of the people and an obligation of the Brazilian state as set down in the Brazilian constitution. Brazilian global health diplomacy starts from the premise that it is the health of the population that needs to be center of attention of diplomacy. One of the best examples of close cooperation within the Ministry of Foreign Affairs and the Ministry of Health in Brazil is global policy on HIV/AIDS, in particular access to antiretroviral drugs, and the presence of health experts was crucial since a diplomat, when discussing his own field of expertise, such as intellectual property, does not necessarily know about specific aspects of the production of drugs in the country or even the policies regarding drug prices. The participation of Brazilian diplomats in the fight against tobacco reinforced the country's leading role in international health forums and has further strengthened the bonds between health and diplomacy. Now, what happened in Brazil illustrates the point that good global health governance begins at the national level. This intensive multi-sector preparation at the national level allowed the Brazilian delegation to intervene in almost all working groups of the negotiation process. Ini terkait negosiasi internasional ya dari Brazil. Tentu saja kalau kita lihat berita sekarang penanganan pandemi di negara tersebut itu kesan yang didapat agak berbeda ya. Tapi memang pada level health diplomasi Brazil cukup baik ya. Lebih dulu dari kita. Walaupun di dalam negeri mereka menghadapi berbagai tantangan. Ya, kita tahu lah, kita baca berita-berita ya. Next please. Challenges. As of today, donor assistance for health has shrunk since the global economic crisis, causing countries to reassess their overseas assistance programs and seek ways to collaborate with other donors, while also pursuing greater domestic commitments to health programs. Previously, poor countries have made progress in their income and capacities that raise their ambitions to be equal partners and not simply aid recipients. Navigating this trends will require significant engagement from all sides, with attention to negotiation around issues of country ownership, health system, and fostering equitable and efficient bilateral, trilateral, and multilateral partnerships. Meanwhile, players must now address a set of newly recognized health issues that face developing countries, such as non-communicable diseases and mental health, alongside the unfinished business of reducing illness and death from preventable infectious diseases, and promoting maternal and child health. Global health diplomacy requires attention to issues of country ownership and fostering equitable partnership. Ini konsep yang penting ya untuk terutama bagi negara-negara berkembang. Next please. A way forward. Will global health diplomacy become a defining characteristic of the global health response in the next decade? Given recent trends, we might expect that it will continue to grow in importance. But in order to ensure international engagements on health and foreign policy are truly a win-win, both foreign policy practitioners and global health proponents need to engage more substantially. In an increasingly interdependent world, it is in the long-term interest of every country to have safe, prosperous, and healthy populations in partner countries, and the diplomatic community would do well to recognize that the global health agenda is a strong tool to achieve this goal. Jadi para diplomat itu perlu sadar bahwa global health agenda itu adalah salah satu prioritasnya. Likewise, global health experts could make greater efforts to understand and engage with foreign policy practitioners by keeping diplomatic leadership and Indonesian missions abroad well informed of their activities, and by clearly drawing the link between these activities and the broader policy objective of foreign policy. The global health experts need to engage with foreign policy practitioners by keeping diplomatic leadership and Indonesian missions abroad, kedutaan besar kita di luar, well informed of activities. Jadi ada koordinasi yang erat. Global health proponents also have additional opportunities to seek more visibility and to push for a seat at the table within the context of a broader set of international diplomatic issues with health implications such as climate change and human trafficking. Jadi sejumlah isu yang tidak terkait, yang biasanya tidak dikaitkan dengan health, itu sebetulnya memiliki komponen health di dalamnya. Jadi perlu juga pakar global health ini duduk di dalam meeting-meeting atau negosiasi terkait misalnya tadi climate change and human trafficking. At home, we need to start doing this better. A, develop global health strategy by optimizing Indonesia's comparative advantages in the global health sphere. B, identify the architectural and policy challenges to be addressed and defining Indonesia's global health priorities and objectives. C, mapping areas where Indonesia's foreign policy affects global health. And D, promote intensive collaboration across line ministries and engage key partners and stakeholders. Yang D tadi ya, promote intensive collaboration across line ministries and engage key partners and stakeholders. Now, those are that is my presentation, Pak Ferdinand. Mudah-mudahan ada waktu. Saya ingin menjawab tadi. I enjoy the session before this, and one of the most important question is whether which is better, the health practitioners trained in diplomatic way, or Indonesian diplomats to be trained in about health issues. Permit me to answer that in Indonesian language, Pak Ferdinand.
Yes, please.
Ada dua aspek di sini. Aspek pertama adalah aspek kemampuan. Ya. Dalam hal ini saya mendorong bahwa para pakar kesehatan yang terkait, ya, yang relevan dengan diplomasi kesehatan, itu perlu memahami cara-cara diplomasi. Jadi mereka perlu memiliki kemampuan untuk diplomasi. Sebaliknya diplomat kita yang biasanya mungkin kurang paham soal kesehatan perlu memahami pentingnya isu-isu kesehatan. Jadi ini ada masalah pengetahuan dan kemampuan. Dua-duanya perlu ditingkatkan, katakanlah. Tidak mungkin health diplomasi dilakukan sendirian oleh diplomat, karena fokusnya berbeda. Sebaliknya, para pakar kesehatan, mereka memiliki substansinya. Mereka pakar di dalam substansi itu. Tapi arsitektur, infrastruktur diplomasi di luar, tata cara, ya, katakanlah apa istilahnya, ya, permainan dalam arti luas, ya, permainan diplomasi, termasuk menghadapi main kayunya negara-negara lain. Ini saya bicara berdasarkan pengalaman, ya, main kayu, Pak. Kalau sudah bicara soal kepentingan negara itu kan begitu, ya. Itu biasanya sudah dipahami oleh para diplomat. Jadi dari sisi kemampuan, dua-duanya perlu ditingkatkan. Diplomat perlu memahami pentingnya isu kesehatan, pakar kesehatan juga perlu memahami cara-cara diplomasi. Tetapi masalah diplomasi kesehatan bukan hanya soal kemampuan, Pak Ferdinand. Banyak sekali saya yakin, ya, pembicara sebelumnya, termasuk tadi juga presentasi saya di awal-awal, menjelaskan bagaimana rumitnya, bagaimana lintas sektoralnya isu ini. Ya kan? Jadi ini bukan hanya masalah kemampuan orang per orang, tapi ini masalah isu yang semakin lama semakin lintas sektoral. Lintas sektoral ini sudah bukan masalah kemampuan orang per orang lagi, tapi masalah penanganan bersama, koordinasi bersama, koordinasi erat antar organisasi, antar kementerian, antar lembaga yang terkait dengan isu kesehatan. Itu Pak Ferdinand. Jadi saya kira kalau kita pahami, kalau kita lihat apa yang kita sudah lakukan, ya, itu sebetulnya kelihatan kita nggak bisa jalan sendiri. Nah, jangan sampai kita terjebak lagi ke dalam mindset zaman tahun 70-an, ya, tahun 80-an, di mana masing-masing itu jalan sendiri gitu. Karena sekarang isu di luar itu sangat lintas sektoral. Pak Ferdinand sendiri saya kira sudah paham. Pak Ferdinand sering mengikuti negosiasi kesehatan, ya. Artinya bagaimana isu agenda kesehatan sebetulnya ini berlaku bukan hanya kesehatan, semua isu. Ini kebetulan kita sedang bicara soal kesehatan, jadi saya ambil contoh kesehatan. Itu kait-mengkaitnya dengan masalah perdagangan, kepentingan human rights kadang, ya. Kepentingan intellectual property rights. Dan ini masing-masing di dalam negeri ada kementerian sendiri yang menangani isu-isu tersebut. Jadi kalau kita keluar di negosiasi keluar itu di luar kita perlu kerjasama dengan itu tadi, ya, semua pihak yang memang memiliki infrastruktur diplomasi itu. Tapi yang penting juga di dalam negeri itu nanti follow up apapun yang kita hasilkan sebagai hasil dari negosiasi di luar itu perlu dikoordinasikan bersama oleh kementerian-kementerian atau lembaga atau organisasi di dalam negeri. Bahkan sebelum keluar pun kita perlu mengadop national platform tadi, ya, saya sempat singgung. Apa sih kepentingan Indonesia? Gitu. Kalau kita bicara soal tobacco misalnya, ya, kita balik ke masalah isu tobacco kan. Apa sih kepentingan industri? Apa sih kepentingan Kementerian Pertanian? Apa sih kepentingan HKPI di bidang petani tobacco, petani tembakau? Nah, ini semua menjadi faktor-faktor yang mempengaruhi. Jadi sekali lagi kalau tadi pertanyaannya sebetulnya mana yang lebih baik, ya, apakah diplomat yang ditingkatkan kemampuannya supaya bisa negosiasi kesehatan, ataukah pakar kesehatan yang perlu ditingkatkan kemampuannya supaya bisa bernegosiasi. Kalau soal kemampuan, dua-duanya harus, kalau menurut saya, ya. Tapi ini bukan soal kemampuan orang per orang sendiri. Ini adalah isu lintas sektoral yang kita hadapi dan harus dihadapi secara nasional, secara lintas sektoral juga. Saya kira itu jawabannya Pak Ferdinand.
Baik, terima kasih Prof. Thank you for very comprehensive presentations and already answered the previous questions that raised by the first speakers. I already see there are so many important issues that has been already raised by Ambassador Sunu presentations, like the most important things in the coordinations, yeah, how to implement the global commitment into national, yeah. It could be failure if we have no leadership actually and consolidations, yeah, among relevant stakeholders related within the countries that has been already raised. And then how about the negotiation process behind the FCTC and IHR has already been raised? It's very a complex issue, not a matters of health actually. So I would like, in terms of time, there are only actually 17 minutes left. So we have 6 questions. Maybe I would like to raise some. First, from Pak Adi Sanjaya, dear Pak Sunu, what are the frequent weak points of negotiation that an Indonesian citizen should be aware of while performing global health diplomacy? Ya, silakan Pak.
Ya, terima kasih. Ini pertanyaan yang sangat relevan. Ya. It's a very good question. The weak points that Indonesian citizens should recognize.
For negotiations, yeah.
negotiations. Well, actually, I have emphasized the importance of national platform, right? So usually, if we go abroad to attend a meeting or to attend a negotiation session, what we should do is we should ensure what is the national interest, what is the national platform with regard to that, with regard to the issue of the negotiation. And this is not this is not an easy task, because we have to meet with various parties. We have to meet with various organizations and ministries. So before we go outside, we go abroad, we need to ensure what is the country's interest in that issue. Sometimes we don't do that. Sometimes we don't do that. Not because we don't want to, but sometimes we don't have the time to do that. And sometimes we don't know who are involved, actually, who would be affected by this or that issue. Right? So if we take the issue of health, for example, sometimes we only see that issue as in technical terms. Oh, this is a medicinal, an issue of medicine and so on. Without understanding, without knowing in advance that this so-called technical issue is actually or would actually impact on other issues or other actors. So it's not an easy task. And the second, the experience of the negotiator. Indonesians are sometimes naive, right? Saya tidak tahu apakah ini bagus diungkapkan dalam bahasa Inggris. Tapi banyak orang kita kadang tidak melihat tantangannya. Nah, sekali lagi ini perlu koordinasi lintas sektoral, bukan hanya di dalam negeri, tapi juga pada waktu negosiasi tadi. Perlu memanfaatkan infrastruktur diplomasi yang sudah ada, karena biasanya kita dari dalam negeri tidak tahu, misalnya kita berhadapan dengan negara A dan negara B. Itu posisi negara A dan negara B itu begitu, kenapa sih? Nah, ini kesulitan ini, tantangan ini lebih parah kalau kita tidak ada koordinasi internal. Karena negara A dan negara B 90% saya yakin itu posisi mereka itu sudah posisi lintas sektoral. Agak susah kalau kita melihat dari kacamata sektoral untuk melihat posisi negara lain yang sebetulnya lintas sektoral. Tidak match ya, tidak simetris. Nah, ini yang kadang-kadang kita susah melihat, kita tidak bisa melihat ini. Nah, one of the maybe most important is that we have so many assets. Kita punya kemampuan banyak sekali. Kita punya banyak sekali hal yang dicari negara lain juga. Dan itu kadang kita tidak tahu bahwa kita itu kuat. Kita tidak tahu leverage kita apa. Nah, ini salah satu masalah di dalam negosiasi. Kita tidak tahu leverage. Karena kalau kita bisa menekan lawan negosiasi, kalau kita punya leverage. Tapi hal ini jadi masalah kalau kita sendiri tidak paham leverage-nya apa. Leverage kita itu apa? Indonesia itu begitu luas, begitu banyak aktornya, begitu banyak kait-mengkait yang tidak selalu saling berkoordinasi, tidak selalu saling tahu satu sama lain. Jadi itu menyebabkan kita juga tidak paham 100% apa sebetulnya kekuatan kita yang sebenarnya. Pak Ferdinand, I don't know whether it is enough ya, tapi untuk sebetulnya banyak ya, dan kalau memang tertarik mungkin waktu lain kita bisa bicara baiknya dalam bahasa Indonesia, karena ini menyangkut banyak hal yang mungkin agak sensitif sebetulnya.
Yes, that is already in our case study, Mr. Ambassador, that we have make a simulation in case study too, like understand like country Saturnus, Uranus. The participant do not only focus about their countries they choose, but other countries also in negotiation process. So one question, and we have only 5 minutes left actually, and there are several questions left. So I'm asking to the MC, so is it possible to extend a few minutes to choose? I will choose.
Sure, Pak Ferdi, I think.
Yes, there are so many actually, but I'm sorry, I have to choose one. It seems Prof. Adik would like to deliver the question. That's so very long questions here. Prof. Adik?
Yeah.
Would you mind to deliver by yourself the question, Bu? Yeah. Yeah.
If you don't mind, if there are other questions from facilitators or participants, I'm okay. So give the floor first for the facilitators and participants, and I can later send my question to His Excellency.
Okay, great. The question number 2 from the participant, Pak Rahbudi, yeah. Negotiating global health is not purely public health issue, yes. For example, in tobacco control, it involves beyond public health, such as trade policy, human rights, environment, customs, etc. From that lesson learned, please suggest the model of intervention before we raise the issue about suicide prevention, since this issue raising in SDGs. Pak Rahbudi is from mental health department, so he's concerned about the issue related health, mental health. For example, the suicide prevention. Yes, Pak Sunu, please.
Yeah, yes. Unfortunately, I'm not following issues of suicide prevention closely. But my suggestion is that if you are going to have a meeting on that, for example, several months away or several weeks away, you can organize interministry lintas kementerian, rapat lintas kementerian, interministry meeting for that, listing the agenda of the suicide prevention meeting, so that the participants to that interministry meeting would be prepared, would know what to expect, what to say in that interministerial meeting. So Ini maaf saya karena saya tidak paham betul ya mengenai suicide prevention. Nah, tapi koordinasi itu bisa dilakukan dengan rapat persiapan. Katakanlah untuk meeting, menghadapi meeting gimana begitu, atau bahkan untuk menanggapi suatu dokumen misalnya, entah itu dokumen WHO atau dokumen apa, itu bisa diadakan rapat lintas kementerian. Nah, tentu saja sekarang mungkin lebih gampang ya karena virtual ya, karena virtual. Jadi tidak perlu sedia makan siang dan sebagainya. tapi mungkin yang perlu ditegaskan atau perlu pastikan adalah bahwa mereka yang diundang adalah yang benar-benar paham isunya gitu. Nah, misalnya dari sisi Kemlu, siapa yang menangani Sustainable Development Agenda tadi ya, siapa yang mungkin dari sisi HAM-nya bagaimana misalnya. Itu masing-masing ada unit yang berbeda itu di Kemlu yang menangani.
Oke.
Jadi itu mungkin.
Baik Pak Dubes, one question from Dr. Imran, from your experience, which one bring more benefit, formal negotiation in the assembly or informal lobby? What should we prepare in informal lobby?
Yeah. We have to know in general we have to know what are the going thinking. What are the thinking of most people, most countries about the issue at hand? What are the position of key countries? We call them key countries on that issue, and then from that we can decide whether we should approach this or that country. Jadi kita perlu tahu dulu, misalnya ini kan mengenai negosiasi ya. Pertama, sebetulnya bagaimana sih pandangan orang tentang isu yang akan dinegosiasikan ini? Lebih banyak yang setuju, lebih ini ada yang ingin reformasi, ada yang ingin memperkuat, ada yang ingin menunda gitu. Nah, kira-kira arahnya kemana diskursus global mengenai isu ini? Kemudian posisi masing-masing negara itu bagaimana? Negara-negara kunci ya, negara-negara yang penting. Nah, dari situ, dari posisi negara-negara itu kita bisa tahu sebaiknya kita mendekati negara mana. Kita bisa memperkuat memperkuat posisi dengan negara-negara yang sehaluan dulu, ya kan? Yang kira-kira idenya sama, yang posisinya kira-kira sama dengan kita. Jadi kita perlu ada koordinasi dengan mereka. Baru nanti bagaimana caranya menghadapi negara lain. Nah, ini juga kadang terkait dengan sejauh mana kita punya hubungan bilateral. Misalnya hubungan bilateral kita dengan Korea itu dekat sekali. Dengan Jepang kita dekat. Tapi dalam posisi tertentu di bidang kesehatan kita berbeda. Nah, apakah ada yang bisa kita lakukan di situ? Trade off. Ya? Apa istilahnya? Saya kasih ini, kamu kasih itu. Jadi apa? Trade off ya, trade off. Nah, di dalam kalau kita dekat hubungan bilateral biasanya ada tuh bisa kita upayakan trade off itu. Nah, juga tadi itu tuh jangan lupa kita tahu dulu kekuatan kita di mana. Posisi kita begitu, kekuatan kita di mana. Karena dalam negosiasi kalau kita mau trade off, kita harus tahu kekuatan kita. Jangan kita mudah mengalah kepada negara besar kalau ternyata kita sebetulnya punya hal yang penting bagi mereka. Kadang kita silau gitu ya, wah ini kan negara besar gitu. Lupa bahwa kita juga negara besar. Ya kan? Banyak orang Indonesia tidak sadar bahwa Indonesia negara besar. Anggota G20, negara terbesar keempat ya dari sisi negara jumlah penduduk, dari sisi macam-macam kita punya macam-macam juga. Jadi apakah yang perlu dilakukan formal negotiation atau informal negotiation? Dua-duanya perlu. Sebetulnya tergantung. Kalau misalnya itu tidak terlalu susah negosiasinya, ya, isunya tidak terlalu rumit, biasanya ya muncul di meeting itu aja. Kita lobby dalam konteks meeting itu. Waktu makan siang, atau di koridor, atau apa gitu ya. Atau sebelumnya kan ada pertemuan-pertemuan bilateral sebelum meeting atau pada waktu meeting di sela-sela meeting. Tapi kalau isunya sangat sulit, apalagi mencakup berbagai isu lain, ya, itu kadang memerlukan pertemuan-pertemuan informal di luar periode meeting. Jadi tergantung isunya juga. Ya.
Baik, thank you. Thank you, Pak. I will extend the time until 12:15 with the permission of Pak Dubes and participants because there are several questions to be raised. I would like to raise a specific issue raised by Pak Dito. Dear Pak Sunu, in your presentations, you raised that in Brazil, MOFA and MOH are having close cooperations. What do you think about cooperation between the two ministries in Indonesia? I mean, the Ministry of MOFA and MOH, from your experience. And what do you think? Is there still room for improvement? Ya, Pak.
Maaf tadi siapa yang nanya?
Pak Dito, Biro Hukum kita.
Oh, Pak Dito.
Ya,
ya. Begini. Memang kalau WHO, ya, semua surat menyurat resmi WHO itu ditujukan ke dua kementerian, Kementerian Kesehatan dan Kementerian Luar Negeri. Nah, Kementerian Luar Negeri dalam hal ini yang pertama menerima adalah PTRI Jenewa. Jadi dari sisi negosiasi lapangan atau dari sisi penanganan lapangan itu Jenewa. Tentu saja Jenewa lapor ke pusat, yaitu di Jakarta ya, Kemlu pusat. Nah, itu dari sisi Kemlu-nya. Nah, dari sisi Kementerian Kesehatan setiap tahun itu tentu saja ada hajatan besar, ya istilahnya hajatan besar WHA yang tingkatnya tingkat menteri ya, Menteri Kesehatan, dan itu difasilitasi oleh PTRI Jenewa. Artinya PTRI Jenewa yang memfasilitasi semua kalau mau delegasi ya, mulai dari delegasi sampai Menteri Kesehatannya gitu. Nah, itu yang terjadi dulu-dulu begitu ya. Tapi sejak 2005, sejak dulu kita katakanlah 2005 ya seingat saya, itu ada kesadaran, dan inilah sebetulnya saya melihat munculnya diplomasi kesehatan itu tahun itu. Ya. Diplomasi kesehatan yang, kalau saya bicara diplomasi kesehatan, ini berarti yang lintas sektoral. Bukan diplomasi oleh Kementerian Kesehatan, tapi diplomasi kesehatan nasional. Nah, kalau kita bicara diplomasi kesehatan, ini kan sebetulnya diplomasi nasional. Nah, itu muncul sejak 2005, dan itu memang disitulah mulai adanya bibit-bibit close coordination ya antara Kementerian Luar Negeri dengan Kementerian Kesehatan. Nah, apa yang kurang? Nah, saya gimana ya? Terkadang penanganan isu ataupun sejauh mana kerjasama erat itu tergantung dari siapa orangnya. Gitu. Ini masalah di mana-mana ya, bukan hanya Kementerian Kesehatan atau Kemlu, tapi di mana-mana, terutama di Indonesia ya, itu terjadi. Jadi ini yang dikhawatirkan. Saya sih melihat sekarang masih ada lah gitu ya. Tetapi ke depan yang saya khawatirkan adalah kalau orang-orangnya sudah berganti, ini lalu balik lagi ke jalan masing-masing. Gitu. Nah ini karena itu tadi akhirnya siapa orangnya itu yang akhirnya menjadi penentu, bukan lagi mekanismenya. Gitu. Nah ini yang saya khawatirkan. Tapi saya sih melihat sekarang masih oke gitu ya, masih oke. Mungkin Pak Ferdinand sendiri bisa jawab itu sebetulnya.
Baik, Pak Dubes, akan kami jawab secara informal. Semoga tetap baik ke depannya. Ya, Pak Dubes, ini ada pertanyaan dari Reza, cukup panjang ya. Hanya saja saya ingin meningkatkannya dalam bahasa Indonesia, bahwa pernah satu saat pada saat pembahasan di WHA membahas tentang poliomyelitis eradication resolutions ya, karena Indonesia disassociate dengan adopsi dari resolusi tersebut. Jadi itu tetap karena konflik of interest dengan kita punya kapasitas nasional untuk memproduksi IPV dan kita juga melihat belum siapnya negara-negara untuk melakukan transisi ya BOPP gitu. Mungkin Pak Dubes juga mengikuti isu ini. Jadi bagaimana posisi resolusi tersebut? Apakah valid kalau Indonesia melakukan disassociate? Apa implikasinya bagi Indonesia kalau associates gitu kan? Dan is disassociating oneself from resolution a common thing? Apakah hal yang biasa melakukan disassociate tersebut? Silakan Pak Dubes.
Ya, kalau di dalam konteks negosiasi internasional itu biasa melakukan reservasi ataupun disassociation terhadap bukan hanya keseluruhan, terkadang dan sering-seringnya itu disassociate-nya itu terhadap paragraf tertentu ya, terhadap pasal tertentu. Jadi bukan terhadap keseluruhan dokumen gitu. Itu biasa. Nah, tapi memang seperti tadi dijelaskan sebelumnya oleh Dr. Pham, resolusi WHA itu tidak legally binding kan? Kalau saya tidak salah ingat, itu tidak legally binding. Memang diharapkan karena negara-negara sudah setuju, sudah mendukung resolusi, maka seharusnya menjalankan resolusi itu. Tapi walaupun tidak legally binding, adalah sangat tepat kalau menurut saya ya, kalau kita mengadakan disassociation atau mengadakan reservasi terhadap pasal-pasal yang kita tidak setuju. Karena walaupun di dalam negosiasi, walaupun kita tidak diharuskan secara hukum katakanlah untuk mengikuti suatu aturan, tetapi bagaimana posisi kita terhadap suatu isu itu memang harus kelihatan. Kalau tidak, kalau kita rahasia seolah-olah ya, itu nanti respek orang berbeda gitu, dan juga agak susah untuk kita negosiasi yang sama, hal yang sama di masa depan. Jadi kalau kita sudah menyatakan diri tidak setuju terhadap suatu pasal, itu sudah menjadi merek kita katakanlah ya, merek kita. Dan itu bisa dianggap bagus, ya, dalam arti bahwa di antara negara berkembang itu Indonesia yang punya posisi begini. Dan itu bisa dijadikan tonggak bagi kita, bagi proses negosiasi kita ke depan, bahwa Indonesia begini. Gitu. Kita bisa cari teman, bisa cari memperkuat posisi kita, bisa juga kita berbuat macam-macam, tapi itu bisa menjadi tonggak bagi negosiasi kita ke depan dalam isu yang terkait dengan ini. Memang sebetulnya di luar itu, ya, di luar apakah reservasi itu biasa atau tidak biasa, yang tadi saya jawab biasa gitu ya. Hal lain yang terkait dengan hal ini adalah bahwa adanya ketentuan IPV ini bisa dilihat dari sisi persaingan industri, bukan semata-mata pertimbangan-pertimbangan kedokteran. Ya, saya kira sudah paham ya, Pak Presiden sudah tahu lah soal ini. Jadi ini sekali lagi membuktikan bagaimana kait-mengkait antara aturan-aturan kesehatan dengan kepentingan industri. Terima kasih ya.
Yeah, sorry Pak Dubes, one more question left from Ibu Nurjana. I will speak in bahasa to make it short. Apa yang kita lakukan apabila ada international partner yang selalu membantu NGO, padahal NGO tersebut menggunakan uang itu untuk meng-attack government policy? Silakan Pak Dubes.
Iya, ini memang masalah di mana-mana ya. Tentu saja ini tergantung dari bagaimana ketentuan nasional kita. Ya. Peraturan nasional mengenai NGO, peraturan nasional mengenai lalu lintas dana, ya, peraturan nasional mengenai bantuan asing, gitu. Memang secara demokratis, secara umumnya, ya, kalau konteksnya adalah negara demokratis, bisa aja ini terjadi, gitu, bisa terjadi. Nah, tapi sebetulnya ada banyak hal yang bisa dilakukan juga, ya. Kita lihat saja, bahkan Amerika juga sangat ketat ya mengawasi arus lalu lintas dana kan ya. Nah, kita juga bisa dari sisi misalnya penanganan NGO asing itu juga ada bisa kita lakukan sesuatu di situ. Tentu agak susah kalau kita larang secara jelas mungkin ya. Sekali lagi tergantung ketentuan nasionalnya mengenai itu apa. Tapi mungkin ada hal lain yang bisa kita lakukan di situ. Bagaimana caranya tentu ini tergantung dari banyak faktor juga. Tapi kira-kira ini menyangkut ketentuan nasionalnya bagaimana ya. Jadi mengenai NGO asing, mengenai lalu lintas dana, dan mengenai bantuan asing. Dan juga sejauh mana kita bisa memagari, katakanlah, memagari bantuan asing, memagari kiprah NGO dan sebagainya. Tapi memang sekali lagi kalau konteksnya adalah sistem yang demokratis, kita hanya bisa secara tidak langsung ya mengupayakan hal tadi secara tidak langsung melalui peraturan biasanya dan melalui tergantung ya. Saya tidak bisa memberikan lebih detail mungkin karena tidak tahu juga organisasinya begitu.
Ya.
Tapi ini ada kira-kira begitulah
ya.
Pak.
Baik Pak Dubes, memang harus kita lihat konteksnya, nanti mungkin bisa dibahas lebih detail di dalam kelompok diskusi.
Ya, misalnya gini ya, masih ada waktu Pak?
Ya, silakan.
Ya, misalnya gini.
Ditambahkan?
Soal peraturan tadi ya, misalnya ini di Papua itu banyak organisasi NGO asing yang berkiprah di sana ya, yang katakanlah kurang menunjang persatuan nasional begitu, tapi mereka mendapat dana dari pihak luar. Nah, sebetulnya kita bisa mengimbanginya dengan kita mendanai juga NGO asing, mendanai NGO tersebut untuk melakukan kegiatan-kegiatan yang sesuai dengan kebijakan pemerintah gitu kan. Jadi jangan hanya penduduk setempat melihat wah ini kok yang bantu kita justru orang asing gitu kan. Tapi masalahnya kan terkendala oleh peraturan nasional sendiri bahwa APBN tidak bisa diberikan untuk NGO kecuali untuk proyek-proyek tertentu ya. Tapi tidak bisa kita mendukung operasional kegiatan NGO dari APBN. Bukan berarti ini salah ya, tapi memang itu kendala yang mungkin apakah ada cara lain untuk mengatasi itu? Ya itu yang perlu kita cari bersama mungkin.
Ya. Baik Pak Dubes, memang kita sulit sekali even mengalokasikan dana contributing something to international organization, to UN bodies, to WHO, itu sangat diapresiasi sebenarnya oleh mereka, tapi kita kesulitan sekali dalam prosedurnya, bahkan sampai ke DPR segala untuk memperjuangkan itu.
Ya, itu dia.
Ya, terima kasih Pak Dubes. Thank you very much. So many information have we got. And please give applause to Pak Dubes, everyone. And then please hold Pak Dubes because we would like to take a picture. I think MC will coordinate about it, and I give back to MC.
Sure, thank you, Pak Ferdi. So to keep some memories with us within the second asynchronous sessions, so we will take the picture with the IT instructions. The IT, do you already prepare for the photo? And also the participant, the facilitators, please open up your camera before we will have the break time. We are still waiting for the facilitators and also the participants to open up their camera. Okay, sure. IT team, can you take the picture?
Okay, ready?
Right now? Yes.
1, 2, 3.
Smile.
Smile. Okay, next layer. Okay, smile. 1, 2, 3.
Keep smiling, everyone, because we cannot see which layer is being taken the photos of.
Okay, next. 1, 2, 3. Okay, thank you.
Sure, thank you for the IT teams. So thank you also for Mr. Ferdi for being such an accommodating moderator. And once again, please let me also to thank our speakers in the previous lectures that gave us a bunch of insights regarding leadership and negotiations in global health. Therefore, I would like to also express our gratitude to the audience, but facilitators and participants who are still with us and contributed to the excitement of the previous lecture sessions. After this, we will have the break for approximately 1 hour, but because we already passed the time, so we expected for all the participants on also the facilitators to be here again at 1:15 p.m. And we will have the next discussions on the speakers' presentations that posed previously and the next case study in the sessions too. So without further ado, please have a good break and lunch. See you in the afternoon, everyone, and thank you for all the participants, facilitators, and the speakers, also committee.
Thank you.
See you guys.
It's
a good break.
Thank you. Terima kasih Pak Sunu.
Ya, terima kasih Bu.
Thank you Pak Sunu.
Ya,
Bagus banget lecture-nya Pak Sunu. Saya belajar banyak.
Thank you Ibu.
Nanti diundang lagi ya kapan-kapan.
Terima kasih Pak Sunu.
Mari ya.
Hi, Bu Inga.
Halo, Pak Andrew.
We will wait for another facilitators and also participants to be here within 4 minutes, maybe. And please remind all of your group's team member. Thank you.
Yeah.
So we are still waiting for our colleague from the facilitators team and also the participants. Maybe they still have the break, so we will wait for another 5 minutes. Thank you.
Hi, Andrew. Andrew, can you hear my voice?
Hi.
Ya ampun, masih segera aja.
Yes. Oh iya dong. Ibu sah. Aman, Bu.
Andrew, can you put the link for attendance list in the chat, please? I just log in, so I don't have it.
Sure.
Thank you. Thank you.
There. Sure, you're welcome, Bu Sarah. We will still wait for another facilitators and participants, but if you're already here, please rename your name in the Zoom based on the format. If you're participants, change your name into the participant underscore your full name, underscore institutions, underscore which group you are in. And for the facilitator, please change your name into the facilitator underscore name underscore which group you are in. And also, if you do not yet fill the attendance form, please check it in the Zoom chat. Thank you. We already have 35 people here, so we will start now. Good afternoon, Your Excellencies, facilitators, participants, and the committee. Welcome to today's second session of the Global Health Diplomacy in Health Virtual Workshop 2020 with the theme Enhanced Training for Future Global Health Leaders. Hopefully you had a great break and lunch previously. We want to highlight here that we committee hear all of your comments and inputs regarding the virtual workshops, especially the tasks that provided by the committee. In the second session, we believe that the transfer of knowledge between the facilitators and the participants are indeed necessary. So we decided to give some time for the groups to discuss today's lecture's topic without any report that needs to be submitted, fortunately, which will be led by our other outstanding moderator from the World Health Organization, which is Ms. Inga William, MSc. Ms. Inga is a senior level professional with almost 20 years of development and humanitarian experience. She also has significant experience in result-based management and program monitoring, while having a proven track record of sound management and financial planning skills. For her education, she finished her Master of Nutrition Sciences at Justus Liebig University of Gießen, Germany, and Master of Public Health, especially for Health Services Management, at the London School of Hygiene and Tropical Medicine, United Kingdom. Without further ado, Miss Inga, the floor is yours.
Thank you very much, Pa Andrew, for the nice introduction, and welcome back everybody to the second session. I hope you all had a nice lunch and you're full of energy and strength to attack the afternoon session. I would like to thank the organizing committee to provide me with this opportunity to help lead you through the afternoon. And we have two main subjects this afternoon. But before we go into that, I would like to remind you, I hope everybody has submitted their pretest. If you haven't, please do so before the end of the weekend. If you find any questions in the pretest you don't know the answers to, please don't worry. The pretest is really all about subjects that you are supposed to learn about during this course. So you're not actually supposed to know them in the pretest. So if you don't know anything, just respond to your best knowledge. There will be a post-test, and hopefully we will prove that your knowledge after the course is going to be higher than before the course. So please don't look up the answers for the pretest and all get 100%. Just submit what you already know. I also hope that everybody had a chance to submit their position papers on Sakai. If you haven't done so, please do so. If you have a problem or the Sakai platform is already closed for submission. Please let the IT team know, or Parian know, or any of us facilitators. We can help you still submit your papers, but please do so as soon as possible. And that's it from the organization part of things. So this afternoon, we are going to have a discussion in the small facilitator groups, and IT is going to put us into breakout rooms to discuss about the questions Parain is going to introduce in a minute. And then at 2:15, we will come back. We'll come back a bit earlier to discuss in the plenary, but at 2:15, we will hand over and start to get an explanation on the next case study you're supposed to submit. So we will have, I guess it's already 1:30, we'll have about 20, 25 minutes to discuss in the small plenary session. And then we'll come back, in the breakout rooms with the facilitator groups. And then we will come back and discuss in the plenary. And I hope that every group will be ready to share a little bit about how the discussion in the small groups went and what your main points were. I'm not sure we can go through all 10 groups, but perhaps a few of the groups. So please be ready to talk a little bit about how your group discussions went. And with that, I hand over to Parayan to introduce the subject of discussion for the breakout sessions.
Thank you, Bu Ina. Afternoon, Bapak Ibu. Hopefully, we are now coming back stronger after the afternoon break. Yeah. So I don't want to stall too much of our time. We just touched about global health leadership and negotiations by our beloved speakers, Higher Excellencies Mr. Ambassador Pak Sunu, and also Pak Pem Namgyal from WHO-CR. In here, we in the morning session, we were also exposed to some of the good questions on leadership and negotiation and how it plays a role in the diplomatic settings. Without further ado, I would like to introduce some of the discussions for today's sessions. I think the three of the questions were introduced in the morning sessions by Dr. Pem Namgyal, but I would like to add one question for us to discuss about the bridging between leadership and negotiation, and the discussions were pointed out in this I believe that facilitators have the questions already, but if you don't have, please maybe take a picture or maybe start noting the discussion questions that we are going to discuss in a smaller group discussion. To your convenience, as Pa Andrew mentioned, this will not be will be turned into a report for everyone's convenience, so that everyone can start looking later on in case study 3. So question number 1, what is better, to train public health experts in diplomacy and negotiation art, or to train career diplomats in public health? Obviously, all of us have each of our own answers to this, because really we are coming from different backgrounds, and that is what we need to have rich discussions later on this question. And next one is, what are some of the measures you would suggest to enhance the efforts by the government of Indonesia to strengthen global health leadership? We have fruitful discussion from Her Excellencies, Mr. Ambassador, Mr. Sunu, and maybe we can extend the answers to these questions later on. The third question is, what are some lessons already learned from current pandemic that may be relevant to global health? This is linked to the topics that we also the context that we also gave in both in case studies. Let us discuss in a small group on this question. And last but not least is, describe an experience you had gone through as leader where you think different pursuit of negotiation, if not better, will yield different result. And we hope that it will stay confidential in this forum, because we want to know that all of you as a leader must have gone through some tough times, and we want to see if in that setting, what you previously had, will different approach of negotiation or communication, or maybe negotiation, if not better, would light different results. From Mr. Sunu, we know that there are many ways of communications into negotiations, both formal and informal. And we were wondering if you can explain to us what would have gone differently if a different approach was taken. So without further ado, and please move after this. We're going to move into small group discussion. Yeah, as Bu Inga suggested, maybe 20 to 30 minutes is enough. And please share to us the result of the discussion in the large forum. And then after that, we will discuss reflection from case studies that we did and the next case studies. I think that's all. Thank you.
Sure, thank you, Sir Yan. So we will wait for the breakout room, but before that, maybe for the participants or the facilitators, do you have any questions regarding the discussions?
Just to be sure. So
Sure, Pak.
what time are we going to collect again, assemble again? 30 minutes or 20 minutes?
Kak Rian, it should be 30 minutes, right? Or Bu Inga?
Yeah, 30 minutes. I think we can make it 30 minutes. Okay, Bu Inga? Is that okay?
Absolutely. Yes. 30 minutes
Yep.
sounds good.
30 minutes.
So until 2 p.m.,
Sure.
right?
Yes.
Okay.
Yeah,
Exactly.
2 p.m.
Pak. Sure. Then if there are no questions on the floor, we can start to open the breaking out room by IT teams. So if you are still do not have any invitation yet for the breaking out rooms invitations, please mention yourself and you can just open your mic. And
Could you please
yes,
put me into any classroom? Or
sure. Thank you, Pak Dias. We will put you into. Katata, are you there? Can you put Pak Dias into whenever the room is
Yeah.
just random?
Okay,
Thank you.
sure. So
Ibu Kania.
thank you.
yeah,
We will also put you, Ibu Kania.
Yeah. Which room?
Just number 3.
Yeah. Okay.
Any question?
Pak Dias to number 3 and maybe Bukania to number 6
Yeah,
because
I already allocate.
Sure.
3.
Last week Pak Dias goes to 2 and or 4.
No, Pak Dias 6.
Thank you, Kak Tata.
Yeah,
Pak Dias maybe you can go to 3, Bukania to 6.
Okay. Okay. To help me to faster this progress, can you rename your names, or I need to search by one your locations of group?
Ibu, there are also Bu Vita and Bu Mia. And also Bu Isna.
Alvina.
Ibu Alfi, do you have any problems to go to the rooms, Bu?
Yes, I haven't got invitations yet, Mas Andrew.
Yeah.
Sure,
You are
Bu
from
Alfi.
group. I would like to ensure you are from group 8, ya, Bu Elvin.
Group 5, Mbak Tata.
Group 5. Okay. Sorry. Thank you. Yes.
Thank you, Bu Alfi.
Thank you, Mas Andrew.
Emang show. Wait.
Ibu, and maybe which group are you in, Bu? Previously? 9. Okay, thank you,
9.
Bu.
Okay.
Will.
Bu Vita.
Any group will do. Thank you.
Okay, Bu. Sure. Ibu Ibu Elvi,
Oh, group 5.
you still here?
Yes.
Yeah, still here.
You should be allocated now.
Do you receive any invitations, Bu Elvi? Maybe it's in the bottom of your... Okay,
Okay.
you already went.
Yeah, need
Ibu
time.
Vita to group 9. Please, Kak Tata. Oh, and Bu Mia can go to the group 10.
Yeah, I think it's still loading.
Sure. And Bu Isna maybe can go
Isna.
to the group 4.
Okay. Okay.
Sure. Then, so if the committee here want to also observe, please do so. Ask the ask. Semangat Kak Tata, semangat, semangat.
Sebenarnya rename itu penting banget loh.
Iya,
Oh,
nanti
iya.
kalau misalkan mereka nggak rename, kita nanti rename otomatis aja kali.
Iya.
Gitu.
Karena kalau rename aku pencet hurufnya searching by numbers and it's automatically changed.
Exactly. Nanti kita bisa next time kita namain satu-satu gitu.
Iya,
Kalau
dicekin.
kan aku senggang kan, dicekin.
Itu nggak bisa ini ya, kayak recurring gitu loh. Jadi sekali kalian masukin mereka ke grup, itu akan berlaku terus gitu loh.
Nggak bisa, Prof.
Nggak, Prof.
Nggak bisa ya?
Iya. Halo Ibu Evelina. Boleh sebutin, Bu, grup berapa? Masih di mute, Bu?
Saya di grup 8.
Oke. Tolong Kak Tata.
Wait.
Siap Ibu Evelina. Ditunggu.
Wait, I think. Wait. Ibu Evelina. Sorry ya.
Grup.
I think I have internet connection problem because like I cannot see the list, the name of the Ibu Evelina.
Do you want to transfer the host to me? Might be.
Yeah, sure. Yeah. Done.
Sure, thank you. Bu Evelina. I think Bu Evelina is already assigned.
Yeah, but she's still here.
Saya masih di sini.
Iya.
Sebentar ya Ibu ya.
Iya, but the weird things, nama Ibu nggak ada di listnya Bu. Padahal Ibu ada di sini.
Wait. Ibu Evelina, can you go keluar dulu bentar terus masuk lagi, Bu?
Live.
Ya, leave dulu nanti masuk lagi.
Baik.
Ini
Sorry,
kayaknya ada
Bu.
error.
Ya.
Maaf ya Bu ya. Kok bisa tado ya? Oke, Bu Evelina sekarang ada. Ship. Grup baik. Sudah ada ya Bu ya invitation sih? Sudah meluncur. Sip Kak, aku balikin nih ke Kakak.
Kak Rian, halo. Andrew, I would like to ensure like the agenda after this 30 minutes of discussions. I just stopped the recording.
They will discuss, Kak. Kan nanti jam 2 selesai discussion. Habis discuss, nanti mereka kan balik